All right, Nithishri, over to you. You're live.
Yeah. Hello, everyone. Good afternoon, and a warm welcome to all the pathologists out there. I welcome you all for the KCIAPM Virtual Slide Seminar for the month of August, conducted by R V Metropolis Laboratory, Bengaluru. Myself, Dr. Nitya, member of Social Media Subcommittee, working currently as a senior resident at General Hospital, Jayanagara, Bengaluru. I am glad that I'll be moderating the session for today. At the outset, I request all those who have joined us to share the link with your friends and colleagues so that they can also join us in live and be benefited by the slide seminar held today. Our KCIAPM team would like to thank the Morphol Labs for digitalizing all the slides for the benefit of all our members. We will have 8 cases today, which will be presented by 8 postgraduate residents all across the state. And I wish all the 8 candidates all the very best. Not taking too much time to begin, we will start our program for today. But before we begin, here are a few housekeeping rules. Kindly set your YouTube resolutions at a minimum of 720 pixels so that you can view our slides clearly, and kindly participate actively by posting your questions as well as your answers in the chat section or on the comment section in the YouTube. Now, today's slide seminar will be conducted by Dr. Ravi Kumar HN sir, Dr. Vani Ravi Kumar ma'am, and Dr. KV Santosh sir, senior consultant pathologist from R V Metropolis Laboratory, Bengaluru. I would like to welcome Dr. Ravi Kumar sir. Over to you, sir.
Thank you so much, Dr. Nitya. I think this is the right time we have started. Thank you so much for that, and good afternoon, everyone. And at the outset, let me thank the organizers of KCIAPM for giving me this opportunity for RV Metropolis to share their knowledge, especially the slide seminar. And I welcome all of you for this seminar. Thank you so much.
Vani ma'am, would you like to say something?
Yeah, good afternoon, everybody. And once again, I would like to thank KCIAPM for this opportunity. Every year, almost from the past, I think 10 to 12 years, we have been regularly conducting these slide seminars. And all 3 of us having teaching background, we really enjoy teaching. And I hope that today the postgraduates as well as the other students will really enjoy the teaching session today. Thank you.
Thank you, ma'am. Santosh sir. Would you like to say something, sir, before we start the program? Okay, I think there is some problem with the audio. Now, the format of our slide seminar will be something like this. We have already shared 8 slides with you all. I hope all of you have checked with the slides, and most of you have also sent us a few of your provisional diagnosis too. Now, we will begin the program. I request our first participant, Dr. Bensi. Please introduce yourself and share your screen, start your presentation. Also, one more note to all the contestants, you will be given only 4 minutes for your presentation. Okay.
Shall I start, ma'am?
Yeah. Please introduce yourself.
Good afternoon, everyone. I am Dr. Bensi, third year postgraduate from Anapoya Medical College, Mangalore. I'll be presenting the first case in KCIAPM slide seminar. The history provided was 36-year-old female with bilateral tubo-ovarian mass. Coming to the microscopy, this is a scanner view. We can see a diffuse neoplasm that is composed of monotonous population of tumor cells. Going to a higher power, this is a 20x image where we can see the tumor cells that are arranged in diffuse sheets and in cones with thin strands of fibrous septae. This is 40x image where we can appreciate the individual cell morphology. The cells are medium sized. The cells are medium sized with coarse chromatin, inconspicuous nucleoli, and scant to moderate amount of cytoplasm. And these cells are interspersed with few macrophages and prominent dilated blood vessels. Frequent mitotic figures noted and no areas of necrosis or granuloma seen in the section study. With this clinical history and the microscopy, I would like to give the impression as high-grade lymphoma, probably non-Hodgkin lymphoma. And my DDs are small cell carcinoma hypercalcemic type, then small cell neuroendocrine carcinoma, and the remote DD is Ewing sarcoma. So to confirm the diagnosis, I would like to go for a panel of IHC marker. For lymphoma, CD45, and for further subtyping, CD3 and CD20, and for the proliferation index, Ki67. Then small cell neuroendocrine carcinoma, I'll like to go for synaptophysin and chromogranin. Then small cell carcinoma hypercalcemic type, WT1, P53 and P16, and for Ewing sarcoma, CD99. Thank you.
Kindly stop sharing your screen, Nancy.
Sure.
Vani ma'am, Santosh sir.
Yeah, Dr. Vani ma'am will be presenting, discussing this.
Yes.
Yeah. Yeah. So am I audible?
Yes, ma'am.
Yes, ma'am.
Yeah. Dr. Benzi,
Yes,
I
ma'am.
think you are bang on. You are just bang on, and it was really a very crisp presentation, and you have really done a very wonderful job. Congrats.
Thank
So
you.
the case one, the history we received was, it's a 36-year-old female, bilateral malignant tubo-ovarian mass. The clinician had already diagnosed that it is a malignant, bilateral and malignant. He had already made the diagnosis clinically. So he has removed the entire hysterectomy, radical hysterectomy, bilateral salpingo-oophorectomy, omentectomy, as well as pelvic lymphadenectomy. And we received this specimen, the ovaries were quite enlarged. One was 10 centimeters, other was around 8 into 6 centimeters. And look at the outer surface of the uterus. It is kind of bossylated, and you can see it stretched. The entire capsule appears stretched. We cannot call this as, it has not breached the capsule. It is about to breach. And the cut section, it had lot of solid areas, hemorrhage, necrosis, etc. And this is the other ovary. You can see it's basically a solid fleshy mass. And again, you can see the capsule. It is very stretched out and glistening, and multiple bossylations are seen. So we inked the capsule and we have given the sections. The sections you have all seen. Let me go to the I'm not able to show the morphal slides.
That's because you shared the entire PowerPoint. You'll have to share the screen. Stop
It's okay.
sharing.
Next case, stop sharing. Shall I do?
Yes, ma'am. Stop sharing and this time share the screen one.
Share screen one.
No. Again, the PowerPoint has come up. Click on screen one, ma'am.
Share. Screen one only, I'm clicking.
Okay. And then minimize this PowerPoint, ma'am.
Minimize.
Yes, now
Yeah.
open Morphal.
Yeah. Yeah. So This was the image we have given. As soon as you see this picture, it's blue. It's like an ocean of blue round cells. And immediately, you know, the list of differential diagnosis should immediately come, because there's nothing else apart from these round blue cells, as Benzi has correctly described, very scanty cytoplasm, lot of blood vessels you can see in between interspersed, and they're all rounded, and see these vessels vascular. Yeah, is it visible now?
It's visible now. No.
Okay. And there was not much of, in this slide, there was not much of necrosis, or you could not see. And if you go and see the capsule, it was extending almost till the end of the capsule. Okay. So let me go back to my presentation and show you the pictures from there. And somewhat a vague starry sky appearance also you could see in that, right? And we received the fluid also, the peritoneal fluid. The peritoneal fluid was showing very high cellularity, and you could see these kind of cells. They somewhat look to me like a blast, which we see in the leukemia lymphoma. No, it looked more like that, scanty cytoplasm and pap stain slide, and you could see these cells. Lot of degeneration changes are seen because it's a fluid, and it really looked malignant, and we reported it as positive for malignant cells. And here you can see the inked capsule and the tumor abutting till the end of the capsule. And here this is the hyper, there was a lot of mitotic activity, and there were some nucleoli. So that was the picture. A vague starry sky appearance here. Again, you can see. And another picture. So this is the section from the fallopian tube. You can see the wall of the fallopian tube, the plicae, and the tumor was infiltrating from outside the fallopian tube. Sorry for this little bad picture. And so we reported that these cells are found not only in the bilateral ovaries. We could see that it was infiltrating the cervical stroma, it was infiltrating bilateral parametrium, it was infiltrating the omentum, peritoneal fluid was positive, the pelvic lymph nodes were free from deposits. So extensive involvement with positive fluid. So what was the probable diagnosis with this kind of a picture? So small round cell tumor, probably lymphoma, probably small cell carcinoma. Only these two conditions flashed to my mind, and since it looked more like a lymphoma cells, we thought we will go in for IHC, and the panel we chose was the usual, which is a common lymphoma in the ovary, that is the non-Hodgkin's. It is either the DLBCL or the follicular lymphoma in adults. If it was a child, we would have thought of Burkitt's lymphoma. So we straight away went with the IHC panel for lymphoma, and we got CD20 positive, CD3 positive, that is B cell marker positive, T cell marker was negative, BCL2 and BCL6 both were positive, Ki67 very high index, CD10 positive color, and CMYC positive, and TDT negative to rule out the lymphoblastic lymphoma. So with this IHC picture and with the morphology, these are the IHC images, CD23, BCL2 positive, high Ki67, BCL6 positive, and CD10 positive, CMYC and TDT negative. We received the following DDs from our postgraduates. Majority of them, they have called it non-Hodgkin's lymphoma, bar lymphoma. You have used the term just lymphoma. It will be great if you can be a little more precise. And 14 have given small round cell tumor, and small cell carcinoma was the next important DD. So I have highlighted in red, which are very close to the diagnosis. Burkitt's lymphoma, one candidate has given, I really appreciate, because we did see some kind of a starry sky-like picture. Undifferentiated carcinoma, yes. Whenever we find undifferentiated sheets and sheets of these kind of cells, we have to think of a very poorly differentiated or an undifferentiated carcinoma. However, there was not much cytoplasm. Carcinomas, usually we have cytoplasm. Now, some others have given DS, desmoplastic small round cell tumor. As the name suggests, desmoplasia. That means there should be desmoplasia. There was no desmoplasia, so it is ruled out in the first instance itself. Undifferentiated sex cord stromal tumor. Yes, it is a good DD, but it is quite rare. Most of the sex cord stromal tumor we see will have some sex cord differentiation. Very rare to get this kind of an undifferentiated. Metastatic Krukenberg, there were no signature cells. Carcinoid, see, because carcinoid is somewhat a benign behavior. This is a highly malignant. You could have at least written it as a small cell carcinoma rather than just writing as a carcinoid. Dysgerminoma, no, morphology is completely different, and the others are also, the morphologically it is not fitting. One NET, yes, I would take that also as a good differential diagnosis. So our final diagnosis was a high-grade B-cell non-Hodgkin's lymphoma involving bilateral ovaries, the right tube, cervix, parametrium, and the omentum. Extensive infiltration was seen. There is no lymphoid tissue in the ovaries. So from where the lymphoma is coming? There are some hilar lymphoid tissue. Or you may have teratoma ovary. From that also, a lymphoma can arise in the teratoma. Otherwise, it is from the hilar lymphoid tissue of the ovary. Now, what is a primary ovarian lymphoma versus a secondary? When do you call, what is the criteria to call a primary ovarian lymphoma? 3 criteria. At the time of diagnosis, the lymphoma should be confined to the ovary and there should not be evidence of lymphoma anywhere else in the body. Number 2, peripheral blood, bone marrow, they should not contain abnormal cells. Number 3, if further lymphoma lesions occurs at sites remote from the ovary, at least several months gap should have elapsed between this appearance of the ovary and the extra-ovarian lesions. And primary ovarian lymphomas are very rare. They are less than 0.5% of the ovarian neoplasms, and secondaries are also a little more common than the primary. The common is the follicular lymphoma and the DLBCL are the 2 important non-Hodgkin lymphoma. And in the child, in the younger age group, Burkitt's and lymphoblastic lymphoma. Morphology, I would like to stress one point, sclerosis. Our case did not have sclerosis. If you find sclerosis, which is usually seen in this DLBCL, the cells will get compressed and they become spindly in morphology. It may resemble sarcoma, so it will mislead you. So remember sclerosis associated with lymphomas in the ovary. Another point is in early lymphoma stages, the lymphoma cells will be surrounding the follicles. They will not replace the Graafian follicles. If you remember testicular lymphoma, the seminiferous tubules, around them the lymphoma cells will be going and they will be preserved till the end. So even in the ovary, it will be surrounding the Graafian follicles rather than replacing the follicles. Of course, here it is almost very highly advanced stage and completely it has replaced, there are no follicles. So diffuse large B-cell lymphoma, the centroblast, immunoblast, you find them. Differential diagnosis, you could also think of a poorly differentiated carcinoma and also florid hyperplasia. Especially in the cervix, no, you get lymphoma like florid hyperplasia, but rare in the ovaries. Sometimes sex cord tumor also will become very poorly differentiated, but it is quite rare tumor to see a poorly differentiated sex cord tumor. The close differential in this case, which Bensi has very correctly and perfectly described, is small cell carcinoma of the ovary. 2 types are there, hypercalcemic type, pulmonary type. I did bring up to the clinician, and I should thank Dr. Bafna for this case. He is a very leading gynec-onco surgeon. It is his case. I rang up to Dr. Bafna and asked him, sir, did the patient have elevated serum calcium? He said, no, it was normal. He tested and he said it is normal. So small cell carcinoma, the hypercalcemic type, it will have paraneoplastic hypercalcemia. Again, you will have large ovarian masses, and this is somewhat an epithelial origin as compared to small cell carcinoma of the pulmonary type, where you get the neuroendocrine markers. Here you get more of a epithelial markers. You get CK, EMA, then you have WT1 positive. And this will become a very close differential diagnosis because monotonous small round blue cells with high mitotic activity is seen in this small cell carcinoma but necrosis is a very important feature. In this case, we did not find much necrosis here. The small cell carcinoma of the pulmonary type, that is more of a neuroendocrine, where chromogranin, synaptophysin, NAC, these will be positive. Here again, you get the small round blue cells and a salt and pepper chromatin. Both these small cell carcinomas are very aggressive neoplasms with poor prognosis. Now, what is the prognosis of ovarian lymphomas? Prognosis directly depends upon the stage. So staging is very important. The points of note in prognosis is bilateral involvement, very large size, widespread disease on staging, and a high prognostic index score. So that is about case number 1. That is the diffuse large B-cell lymphoma, high-grade B-cell lymphoma involving both the ovaries with extensive spread. So the differentials already, the PGs we have already discussed. So thank you for this case 1. We will move on to case number 2.
Okay, thank you, ma'am. Case number 2, Dr. Jyotika Kumar. Can you please introduce yourself and share your screen?
Good afternoon. My name is Dr. Jyotika Kumar. I'm a third-year postgraduate from SDM Medical College. Is the screen visible, ma'am?
Yes, you can present.
The case allotted to me was the case number 2 with a history of a 48-year-old female with fibroid uterus. The whole mount view here, we can see a tumor, a blue tumor which is invading into the myometrium. On a scanner view, what we can see is these tumors have a tongue-like projections invading the myometrium. Then these tumor cells are seen invading the myometrium as tongue-like projections. Now, what also was noted was the vascular invasion of the tumor. And here is the vascular invasion, the endothelial lining to confirm it's a vascular invasion. Now coming to the tumor cells, these cells closely resemble the endometrial stromal cells. And these cells have a round to oval nuclei with a finely granular nuclear chromatin and an inconspicuous nucleoli. The cytoplasm is amphiphilic and the cytoplasmic borders are indistinct. Now also what was seen characteristically is the multiple proliferating tiny capillaries which are also seen in the endometrial stroma. Now coming to the differential diagnosis. First differential diagnosis is the endometrial stromal nodule, but the endometrial stromal nodule is a very well circumscribed tumor which will show very minimal invasion into the myometrium or no invasion. Coming to the next differential, it's the endometrial stromal sarcoma, low grade, where all these features were consistent with it. And the mitotic figure count in the low grade endometrial stromal sarcoma will be less than 3 with a low mitotic count, while in a high grade we'll see brisk mitosis and the presence of necrosis also. The fourth differential is a highly cellular leiomyoma, where we see spindle and epithelioid-like cells, but the differentiating point is that will be positive for the smooth muscle actin, but negative for CD10. Now coming to PCOMA, the perivascular epithelioid tumor. So here these cells are round to oval with a vesicular nucleus and a prominent nucleoli. But then the positive staining, this will stain positively for HMB45, which rules out the endometrial stromal sarcoma. So my diagnosis is endometrial stromal sarcoma of low grade. These were my points in favor for the endometrial stromal sarcoma, and the IHC markers which will be positive if done will be CD10, which will show membranous positivity, ER/PR will show a nuclear positivity, and Desmin may come, it is negative usually, but may come positive if there is smooth muscle differentiation. Thank you.
Thank you. Vaniman.
Ma'am, close this PowerPoint so that we can.
My screen is not moving forward.
Click on the right button, ma'am, right side of the mouse button. Right click on the mouse. Yeah.
Yeah.
End this show here.
Yeah, thanks. So case number 2. Jyotika, it was a very good presentation, and I think you have covered at least half of my presentation, so I can cut short on a lot of things. Well done. And it's a 48-year-old female. It was a routine hysterectomy with removal for fibroid. Nowadays, no, the number of hysterectomies have really drastically come down with this Mirena. Mirena is that intrauterine device which releases the hormones progesterone, and it is used for treatment of AUB. So a lot of hysterectomies have really come down. Unless there are some huge fibroids, they remove them. So this was routine like a fibroid, and they've removed. It was laparoscopic probably. So it was sent in pieces like this. I really don't like these kind of bits and pieces. You know, it is kind of not nice to take photographs. It was yellowish, but so the minute we see this kind of somewhat different color, we have to keep in mind, are we dealing with really a leiomyoma or something else? Okay. And it was a very when you all saw the slides, the microscopy, very hypercellular tumor. And exactly as Jyotika has described, blue tumor, tongues of it were infiltrating the pink myometrium. So here pink is all myometrium, blue is all the tumor cells. These blue tumor cells, they look exactly like your endometrial stroma. If you go, this is the myometrium where the tumor is infiltrating. If you go back and see the endometrium, they will look same like a proliferative phase of the endometrium. The blue color cells, exactly like that they look. And there are some spaces like that, into that it is abutting. I did not really think of any vascular invasion as Jyotika has pointed. Maybe we have to demonstrate those endothelial cells by IHC. Otherwise, I thought probably lymphatic spaces, into that they are projecting, because this tumor typically involves the lymphatic spaces. And were they spindly or rounded? I felt more, you know, some are spindly, some are rounded. So I had a little bit doubt what to call this. And short, spindly, ovaloid. Mitosis really not much. It was, as Jyotika has pointed out, it was less than 3/10 hyperfield. And somewhat you could see some vessels, the vascular pattern you can see here. And you could see a lot of blood vessels here like this. And around them, somewhat short, spindly, ovoid, low mitosis, and fragmented tumor infiltrating the myometrium. So what is it? Is it leiomyoma or is it stromal sarcoma? If it is stromal, should we call it high grade or should we call it low grade? And these were the doubts that we had. Okay. So we thought we will go ahead with IHC panel. How to select the IHC panel? For leiomyoma, smooth muscle markers, we can do H-caldesmon. For leiomyosarcoma, because some of you have written sarcoma, you have to do a P16, P53. And we should also keep in mind picomas of the uterine, because we do find picomas with dual differentiation, both melanocytic and smooth muscle. So we have to put HMB45 melanae for melanocytic, H-caldesmon for smooth muscle. And stromal sarcoma, of course, that was the first on top of our mind. We have to put, Jyotika has already explained, ER/PR CD10 and cyclin D1 for low grade and high grade, and a proliferative marker Ki67. ER/PR, already Jyotika has predicted strongly, it has to come positive, so it is positive and very strong positive. Ki was 18 to 20%, and CD10 also was positive and diffuse. Cyclin D1 came negative, because cyclin D1 is the one which will clinch whether to call it high grade or low grade. We did do caldesmon and HMB45, which are both negative, melanae negative. So we have ruled out picoma, and this is the summary of the IHC findings. The list of differentials received from the postgraduates, we received highest is low grade endometrial stromal sarcoma, and 5 of you have just called ESS. You have been non-committal, not committing low grade or high grade. High grade, 1 person has given. Picoma, 3 of you. Leiomyosarcoma, 8. Adenomyosis, 1. I must congratulate the postgraduate who has written as adenomyosis, because it does resemble adenomyosis. To the novice in pathology, to a fresher who is reporting uterus, a hysterectomy, thinking it's a routine leiomyoma, you may report this case as adenomyosis and be happy that you have reported it correctly, because it does resemble adenomyosis. So that's a very good differential, the one who has given us this diagnosis. But it is not adenomyosis because there are no glands. There is only stroma. There are no endometrial glands. So it is not correct in this case. And you have uterine tumor resembling ovarian sex cord stromal tumor. Yes, WHO, when you see the list of differentials for a mesenchymal tumor, this is one of the important tumors. But we didn't think of this in this particular case because nowhere sex cord stromal differentiation was seen resembling some kind of tubules or nests. That was not seen. Carcinosarcoma, no, there was no dual differentiation like this. So this is the list of DDs that we received from the students, and our diagnosis was a low-grade endometrial stromal sarcoma. Why did I choose to put up this case is because we did have a controversy to call it low-grade or high-grade based on some of the morphology, which I will discuss. Endometrial stromal sarcoma is a malignant tumor. It is derived from the endometrial stromal cells. Usually 5th decade, they are large size, 7 centimeters, and they will have extrauterine extension usually. 5 centimeters, please remember this. For stromal sarcomas, 5 centimeter cutoff. T1A, T1B. So this case, more than 5 centimeter, T1B automatically. Another point to remember is, generally, these patients will give history of tamoxifen or pelvic irradiation. Tamoxifen for CA breast. We have reported several cases of endometrial stromal sarcoma, and some of them have had a history of tamoxifen. Usually tamoxifen, they will have endometrial polyps, they will have endometrial hyperplasia and CA endometrium. Also remember, endometrial stromal sarcomas are associated with tamoxifen. Now, low grade versus high grade. This case I have put up to discuss mainly how to differentiate this low grade versus high grade. Low grade, spindly morphology. High grade, rounded morphology. Our case, you can say like in between. If there was some intermediate grade, no, it would have fitted probably. Not very spindly, not very rounded, somewhat short spindly, we can say. Mitosis, high grade, it is very high, more than 10, which Jyotika has already described. Low grade, below 2 or 3 per 10 high power field. Then you have proliferative phase type of endometrial stromal cells, and they may invade the lymphovascular spaces. But in this case, lymphatic invasion, I did agree, but vascular, I'm not really convinced. And in high grade, it will be very, very expansile, permeative and infiltrative. Necrosis is not seen in low grade. In high grade, usually you find necrosis. IHC is very important. ER, PR, CD10, strongly positive in low grade and negative in high grade. Whereas cyclin D1 becomes positive in high grade and negative, not exactly negative, variable you can say, in low grade. So this is the one which will clinch the diagnosis apart from morphology of spindle cells and round cells, mitotic activity and immunohistochemistry. Now, the prognosis, again, it depends upon the staging. For all the cases, prognosis depends whether it is in stage 1 or stage 2, you have good prognosis. And for stage 3 and 4, it will reduce. Another important DD here, which I would like to discuss, is picomas or perivascular epithelioid cell tumor. As the name suggests, it is epithelioid. What is the meaning of epithelioid? Epithelial-like. That means it will have big size with abundant cytoplasm. Did our case have that much of abundant cytoplasm and abundant size? No. But what was common? Tongue-like protrusion. Jyotika told there is a lot of tongue-like infiltration. Yes, picomas will have tongue-like infiltration. So that you have to remember it as a DD in the case. And of course, it is dual differentiation, nanocytic smooth muscle, and your IHC will resolve it very easily. Cell of origin is perivascular epithelioid cell. Morphology also, it can be both spindly and in epithelioid. Epithelioid will be in nest and the spindle will be in fascicles. So that was about case number 2, and I think it was a very good presentation. Thank you all. We will now move to the case number 3.
Yes, thank you, ma'am. Case number 3 will be presented by Dr. Sayeda Husnain Fatima. Please introduce yourself and share your screen for presentation.
You're not audible, Sayeda. Just try once more.
Yes, sir. Just a minute.
Okay, you're audible now.
I can. You can hear me, sir?
Yes, yes.
Yeah. I'll just share my screen. Is this visible, sir?
Yes.
Go ahead, begin your
Yes.
presentation.
Good afternoon, all. My name is Dr. Sayeda Husnain Fatima, and I'm pursuing my PG in Vaidhi Institute of Medical Science and Research Center. And our college is assigned case number 3. So to begin with, the history that was given was a 65-year-old male with a pedunculated lipoma in the left calf. So this is a scanner view. We saw that it was a skin-covered polypoid-like tissue, and there was ulceration noted at the epidermis and also a few congested blood vessels. This is at a low power, that there is irregular thickening or mild acanthosis of the epidermal layer. Just subepidermally, we can see that there is a loose fibrous collagenous stroma and few congested blood vessels, and also they are dilated and few look ectatic. The ulceration, as we move inside a low power, we can see that the epidermis, there is ulceration and it's extending into the dermis. And the ulcer bed shows granulation tissue with mixed dense inflammatory infiltrate. Here we can appreciate that in the area where there is ulceration, we can see a vessel. It looks like a tuft of capillaries that are showing fibronoid necrosis. At a view of a low part, in this view, we are seeing that there are abundant vessels and their focal areas that look like tuft of capillaries that show the fibronoid necrosis, and there are a lot of dilated blood vessels and they are congested. And now vaguely we are noting at this part that they are singly dispersed atypical cells. So let's just see how they are appear to us. So at a power, we are seeing that these are large and they are pleomorphic and they are diffusely dispersed in the collagenous stroma. At a higher view, these atypical cells. So these atypical cells appear to be pleomorphic. Some appear to be stellate shaped and some appear to be binucleated. And they have a vesicular-like nucleus and a prominent nucleoli, and they are diffusely dispersed in the fibrocollagenous stroma. So this is the loose fibrous collagenous stroma. At the right end, we can see that there are proliferations of some vessels, and at the left, we can see that there are dilated vessels which are congested. To summarize, the irregular acanthosis, the ulceration of the epidermis, the loose fibrous collagenous stroma, abundant dilated blood vessels, and the atypical cells in this stroma. So I have two probable diagnoses. One is a cutaneous fibroepithelial polyp with a pseudosarcomatous change, and the second is a pleomorphic fibroma. Actually, both of them overlap, but the difference that is that in pleomorphic fibroma, you have a dense collagenous stroma, and the epidermis usually doesn't show any ulceration. So the points that favor my diagnosis was the age, as 50 years, about 50 years of age, and it was a pedunculated like a polyp. And on morphology, there were no adnexal structures identified, and it was a loose fibrous collagenous stroma, abundant vessels, and there were pleomorphic stromal cells. So we have two markers that we can do. One is a vimentin and CD34 vimentin. We can find that these pleomorphic cells will give you a diffuse positivity. So we have only two probable diagnoses now. Thank you.
Yeah. So can you see?
Yes, ma'am.
Yeah. So case number 3, Dr. Sayeda Husnain Fatima from Vaidehi. A very excellent presentation, very crisp, and I basically liked your approach. It is really very exactly the way I wanted to discuss, and your approach is really good. And I will tell you one more reason why, one more compliment for you. So case number 3, history, 65-year-old female male. He had a calf. In the calf, there was a lipoma. It was pedunculated. So the surgeon just removed that pedunculated mass. It was around 5 centimeters. And when I called that surgeon and I asked him some detailed clinical history, can you give? He replied, Madam, that was just a lipoma. I excised it. It was pedunculated, so nothing much. I wanted to throw it off. But then suddenly I just remembered you and I thought, okay, let me send it to the pathologist. And then I sent it over. I said, sir, that is really so mean. Whatever is going to the dustbin, you're sending it to me. So I was just kidding like that with him. But he just laughed and he said, that's all, no more history about that case. So when we saw the microscopy, I was also a little pleasantly surprised, and immediately I thought, yeah, this slide will be taken extra sections for our next KCIAPM, because it had very glaring, bizarre, giant multinucleated cells, and it was not a lipoma as the clinician told. So that's where this case started. And Fatima has correctly, Saida has correctly described. Let me go back to the slide and show you. Yeah. So you are seeing the surface squamous epithelium with ulcer, and underneath we are finding lot of blood vessels and a loose fibrocollagenous stroma. Few of you, why I am showing is this, there is nowhere you can see adipose tissue or fat. But some of you have written adipocytic tumor, fat tumor, pleomorphic lipoma, like that. So when we don't find fat, I don't think you should be calling any of these lipomatous tumors. Understood? So that is what I wanted to share in this. There was no necrosis, there was no mitosis. The most important thing which was glaring at us is this large number of vessels. See, these are the blood vessels and these kind of bizarre cells around the vessels. Mainly these bizarre cells were perivascular in location. They were not scattered through and through everywhere, and it was mainly perivascular. See, they were so bizarre and so large. And I love seeing these cells. They are so grotesque looking, but they are trying to tell us some diagnosis. And see here, multinucleated like cells are seen. And we received a good number of differential diagnoses, and I had to go back to my Enzinger and read up once again. Thank you, PGs, for giving this big list, which made me go and read some more about soft tissue tumors. Angiomyolipoma, four cases, 4 PGs have given. Did you see all the 3 components? Yes, angio component, yes. Myo component, muscle, I didn't see. Lipoma also is not there. So that's ruled out. Lipoma, pleomorphic lipoma, angiolipoma, see, there is no fat component at all. So I don't think any lipoma tumor will enter into the differential diagnosis in this particular case. Liposarcoma, atypical lipomatous, no, there is no lipo component. Angiolymphoid hyperplasia, there are definitely no that much of lymphoid hyperplasia, lymphoid aggregates are not seen. Eosinophils are not seen. I don't think we can call this entity. Then some of you have called it a neurofibroma, floret-like NF and giant cell NF. Good, it's a good guess. Neurofibroma, yes, there is some spindle cells in the stroma, but they were not really wavy bundles like that was not there. But nevertheless, it's a good differential diagnosis. Another point to rule out this giant cell neurofibroma. Where are these giant cells or these floret-like cells located? In our case, it was predominantly around the vessels, not diffusely scattered. In neurofibroma, everywhere you will find them. Whereas our case, it was mainly perivascular. Pleomorphic fibroma, bang on, one person has given the diagnosis, and I think even Dr. Saida has given that as one of her differentials. Hemangioma, glomeruloid hemangioma. Good guess, because within the vessel, somewhat glomeruloid like you were seeing, so maybe that prompted you to think of this entity, but in that condition, you will not find this kind of perivascular, bizarre giant cells. You will not find them. Hence, we have ruled out that. Nevertheless, a good guess. Fibroepithelial lesion with HSV infection. One person has given this. Very good. Your approach is right. Your diagnosis is wrong, but your approach is very good. We are dealing with fibroepithelial lesion. We are dealing with benign lesion. Somewhat herpes-like giant cells you're seeing. I think you're having a very good approach, but it was not herpes because there was no ground glass nuclei and the patient obviously history is not there. Serology also nothing was done. Then Syed has already given this DD of fibroepithelial polyp with pseudosarcomatous change. Very, very good approach. So the second compliment, Sayada, is it is a pseudosarcomatous. The reason for posting this case in our KCIAPM slide seminar is you have to not jump into sarcoma when you see bizarre cells, giant cells, ugly looking cells. Do not jump into sarcoma. Please think of pseudosarcoma because sarcomas will be very rapidly growing, very big in size, lot of necrosis. They will overshoot the vascular supply. So think of pseudosarcoma, wherein you get this sarcoma like bizarre cells, but they are not sarcoma. So it is called pseudosarcoma. So this is very important. Practically, we see more of these cases rather than the sarcomas. So Sayeda, I appreciate your approach in telling that it is something benign, fibroepithelial, because there is epithelium, there is a polypoid mass. It has pseudosarcomatous change. Very good. Giant cell angiofibroma is an excellent differential diagnosis, and inflammatory myofibroblastic tumor, there is not much of an inflammatory component. Hence, we did not think of this entity. Angiosarcoma, definitely no. Pleomorphic hyalinizing angiectatic tumor, very good differential because there is some amount of angiectasia in this case. Vascular ectatic spaces we are seeing. Pleomorphism is this pleomorphic cells you're seeing, but we didn't see hyalinizing. In this entity, that is PH80, lot of hyalinization around blood vessels. A pink, thick hyalinized wall will be seen. Did we see that in our case here? No, we did not see that characteristic thick hyaline wall. We did not see. Hence, we have ruled out a PH80 tumor in this case. So thank you, students, for this list of differentials, which really kept me on my toes whole of last 2 nights to read up about these entities. So our final diagnosis was a pleomorphic fibroma. Uncommon entity. It is somewhat akin to pleomorphic fibroma of the tendon sheath. There is presence of large pleomorphic cells. There's a collagenized stroma. The common site extremities. Our case, it was the calf. So it fits into the common site, 5th decade. And clinically, it will look like a nevus or a neurofibroma or a hemangioma or even a lipoma, a pedunculated lipoma. IHC, very correctly, she has discussed that we can, there's variable immunoreactivity for smooth muscle, muscle-specific actin. It may suggest some amount of myofibroblastic differentiation, also CD34, CD99, and immunostains for S100 desmin cytokeratin are negative. In this case, we did not do the IHC. You know the reason why? Because it was pedunculated lipoma, the surgeon has removed. He was about to throw it to the dustbin, and now if he asks for additional billing, definitely they will say no, we don't want histopathology only, so why you want to do IHC? So we really didn't do any IHC for this case. The differentials which I want to discuss is the approach to wherever you find pleomorphic cells. Atypical fibroxanthoma. Here, xanthoma cells, foamy cells will be there, but lot of these atypical looking bizarre cells is seen. So that will enter into the differential. Dermatofibroma with atypical cells or monster cells, that also pseudosarcomatous appearance it will have. So these are all conditions with pseudosarcomatous pleomorphic cells. Giant cell fibroblastoma. Somebody has given this, one of the pages, giant cell fibroblastoma, good DD. This is, but why it is against is below 10 years of age. Our patient is not below 10 years. He's, I think, 50 plus. So that's why we have ruled out. It is more common in children. And of course, ancient schwannoma, neurofibroma, some of you have given. These are also very good differentials in this case. But I told you the giant cells will be scattered everywhere, not predominantly localized around the blood vessels. Hence, we have, these are the list of differential diagnosis. And these are my pet cats. They all are very fond of eating together. So my favorite picture I want to share with you. And thank you all for your nice presentations. I really enjoyed. And I end my 3 case discussions.
Thank you so much, ma'am. We have a slight change in the order of presentation. Next case will be the case number 6. Dr. Priyanka. Dr. Priyanka will be presenting the case. Please introduce yourself and share your screen.
Hello, Priyanka. Click on share and then click on share screen.
Yeah, it's on. It's
It is slide 1.
No, sir.
the first slide is visible. It's an image of
Is that
But
your
actually, in
slide?
my screen, I'm not able to see that slide.
mhm.
That's because you're not sharing the content. Share your screen. Stop sharing. Priyanka, try now. Click on share. Then click on screen 1. You're sharing your PowerPoint. No. Okay. Just go back. We are able to see your screen. Your PowerPoint is open.
Yeah, now it's fine. Dr.
Can
Priyanka.
I start, sir?
Yeah. Yes, please start. Introduce yourself and start.
Good afternoon. I'm Dr. Priyanka MP, first year postgraduate student from Sri Siddhartha Medical College and Research Center. I'm here to present case number 6. The history given is 58-year-old male with mass in right popliteal fossa. This is a slide given. It is a well-circumscribed lesion showing a tumor zone, an area of hemorrhage, and coagulative necrosis. In the tumor zone, it shows two different patterns, an area of ramifying vascular channels and an area of retiform vascular channels. The hypover view of the first section shows numerous irregular vascular channels which are lined by pleomorphic endothelial cells surrounded by spindle to epithelioid cells and collagen bundles with intravascular RBCs. Individual cells are round to oval with vesicular nucleus, scant eosinophilic cytoplasm, and prominent nucleoli. At places, these endothelial cells are showing multi-layering with intraluminal budding and papillations, and intracytoplasmic hyaline globules are also noted. The other section shows vessels in reticular pattern, and the endothelial cells are showing hobnail or matchstick appearance. Pseudolipoblastic cells, that is vacuolated endothelial cells, are also seen with occasional mitotic figures. Hemosiderin-laden macrophages are also seen. From these microscopic findings, my differential diagnoses are composite hemangioendothelioma, angiosarcoma, retiform hemangioendothelioma, and Kaposi sarcoma. Kaposi sarcoma will have slit-like vascular spaces surrounded by collagen and spindle cells. The classic type is seen in adults in skin, oral mucosa, and viscera. Though hyaline globules and mitosis are seen, atypia and necrosis are absent, unlike in the section we studied. So that is ruled out. In the second one, it is seen in young adults in distal extremities, especially lower limb. Hyaline globules, atypia, and mitosis are not seen. Basically, it will have reticular vessels with hobnail pattern, which is similar to the section we have seen in the section. So that is under consideration. Angiosarcoma, it is seen in older adults in lower limb or abdominal cavity. It will show hyaline globules, atypia, mitosis, and necrosis. And it will have vascular channels which are lined by atypical endothelial cells. Intraluminal budding and papillations are also noted. This microscopic finding was also similar to which was seen in the section we studied. So that is also considered. Composite hemangioendothelioma is seen in adults in hand and feet. Though hyaline globules are not seen, atypia with few mitoses are present with or without necrosis. It is basically an admixture of benign and malignant vascular components with pseudolipoblast. So that is also considered. In the section we studied, it shows features similar to retiform hemangioendothelioma and angiosarcoma. And as composite hemangioendothelioma can have features of have a combination of different vascular tumors in different proportion, I would like to conclude, based on the microscopic findings we have discussed so far, it has the final diagnosis as composite hemangioendothelioma, which here is a combination of angiosarcoma and retiform hemangioendothelioma. However, it has to be confirmed using immunohistochemical markers, including CD34, CD31, ERG, FLI1, and factor 8. Thanks.
Thank you, Dr. Priyanka. Excellent presentation. You've picked up all the points. Am I audible, everyone?
Yes, sir.
Yeah. You picked up all the points. You neatly described the lesion, and your approach to your diagnosis is also excellent. I'd just like to ask a couple of things to you, Priyanka. You
Yes,
felt that there were areas of coagulative necrosis, right?
yes, sir.
Can you just go back to your presentation and show me like where you felt coagulative necrosis was? And as you go up, I'll just ask you the second question. You thought there were some hyaline globules, right?
Yes, sir. Intracytoplasmic hyaline
Hyaline
globules.
globules. Do you think there could have been RBCs?
Inside the vascular channels, RBCs were present, sir. But
Okay.
apart from that, intracytoplasmic hyaline globules were also noted.
So you felt there were hyaline globules. Were they bigger than RBCs or they were about the size of? Yeah.
It was bigger than RBCs.
Okay. Can you just show me the area where you felt the necrosis was present? The central region, this area where you've marked the arrow, that area? Okay. I'm not
This
very
area, sir.
convinced
Third
about
area.
that point. Yeah, I'm not very convinced about that point. Because if you look at that area, see, it's not a place where there's a lot of tumor cells, right? It's
Yes,
away
sir.
from the area of tumor. I will just go on. If you stop sharing, we'll move to the slide and then I will discuss this case.
Yes.
Otherwise, excellent. Well done.
Thank you.
Okay, is my screen visible to everyone?
Yes, sir.
It is, right? Now
Yes,
I'm
sir.
moving to the slide. Slide is visible?
Yes, sir.
Yes, sir.
All right, right. Okay, so we'll just go discuss this slide now. I'm zooming in. You can see that it's a very well circumscribed lesion, right? Okay, before that, I'll just show you the gross, how it appeared. Oh, looks like it's not moving to the PowerPoint. Yeah. Now my PowerPoint is visible?
Yes, sir.
Yeah, right. So this is a gross appearance. We received this as a 10 into 9 by 6 centimeter, very nicely encapsulated mass. Is my pointer also visible?
Yes, sir.
It is, yeah. You can see this nicely encapsulated appearance on the external surface, a bit of skin on the top, and there is this cut surface which is predominantly hemorrhagic. There is a bit of gritty sensation while cutting, so probably there was calcification seen. And then this is what we are seeing on microscopy. There's a bit of hanging. Yeah. Right, so looks like it's a very well circumscribed or encapsulated lesion. As you go towards the central portion, this is the where you thought that is all necrosis, right? I feel
Yes.
it is all, hemorrhage and debris because of a lot of hemorrhage. If you look carefully, there is an appearance of a vascular wall here, right? And if you zoom in to some places, you will have a picture that resembles, see, if you look at this area, it kind of reminds you of the what area would you call this place? There's no endothelial lining as such very clearly visible. Okay, so it looks like the vessel wall, don't you think so? It looks like the tunica intima, this area. So this area inside, I feel it could be a part of the vessel wall, and what you're seeing is all hemorrhage and the debris that is produced within the vessel wall, probably early thrombosis, probably even calcification occurring in this area. Do you notice? Okay.
Yes.
So I'm not very convinced about the fact that you're saying this is a large area of coagulative tumor necrosis. Okay. All right. So let's go back. Fine. Let's go back to the tissue. This is the area where there is viable tissue all around. And at this magnification, I can make out that it is quite cellular. And when you go in, zoom in, you see a lot of vascular channels, as you correctly described. They are of varying caliber. And you can see that some of them are large and lined by these plump endothelial cells. So they are very plump. They're not the flattened endothelial cells that you normally see in an endothelial lining. So they look, as you said, they look epithelioid, right? And there is some degree of nuclear atypia, not very significant, but yes, there is some degree of nuclear atypia. And if you look at each individual cell, there is a relatively abundant amount of eosinophilic cytoplasm. See the amount of cytoplasm, and nucleoli are also visible. And they're forming, a lot of vascular channels. So this is basically a vasoformative tumor. Okay, it's forming vascular channels of varying caliber. And as you correctly pointed out, there is proliferation of the endothelial lining, and these proliferating cells have, formed tufts or micropapillary protrusions into the lumen, and there is a lumina formation. And what else are we seeing? Okay, somewhere here you can see these blisters with RBCs. I felt these are all RBCs. Look at this one. Is this visible? It's looking like a signet ring, but it's got a vacuole inside, and I feel that's an RBC. So this is a blistering of the cell with an RBC inside that. So all these are just indicative of a vasoformative kind of tumor. So most of the areas that we are seeing show this kind of vasoformative lesion. Plus, you're seeing some areas where there is a solid kind of component. Do you see these areas, solid kind of component, where there are not many vascular channels which are opened up? And then these areas again slit-like kind of vessels. All right. So mitosis is not very high. I'm not able to really make out, prominent number of mitoses, but I do see some degree of nuclear atypia and prominent nucleoli. And the individual cells show this abundant eosinophilic kind of cytoplasm. And if I look at this entire area of vasoformative lesion, I don't see any place where there is coagulative type of necrosis. And when I look at the margins, it is well circumscribed. There is no real infiltrative margins which is extending across this capsule or pseudocapsule into the surrounding tissue. So this is what we are seeing in the slide. Let me move back to my PowerPoint. Okay. So we've already gone through all this. So let me just summarize my findings. So you pointed out the area of hemosiderin deposits and sclerosis. Okay, what are we seeing now? We're seeing a circumscribed tumor composed of vascular structures, a very vasoformative tumor, and focally they are in sheets, very focal area of in sheets. And all these vascular structures are lined by very plump epithelioid appearing endothelial cells with relatively more amount of eosinophilic appearing cytoplasm and having a prominent nucleoli. And you can see a lot of hemorrhage and stromal hyalinization at places. And there is obviously what looks like evidence of the lesion arising from a vessel wall. It is arising from the wall and expanding the wall, but it has not gone into the lumen from what we could make out. The lumen is not, lumen has a lot of hemorrhagic elements. So it is, expanding the wall of the vessel and forming a tumor there. So these are the findings that we can note. And at that point, our differentials that we considered were that we assigned it out initially as a malignant vascular neoplasm, and we advised immunohistochemistry. And at that point of time, we considered two differentials. One, because of the lot of epithelioid morphology of the endothelial cell, we thought of an epithelioid hemangioendothelioma. The second thought that came to our mind was, is it some kind of an angiosarcoma with again epithelioid morphology? So these were the two things that we kept in mind as we moved on. Let's see what your diagnosis is. My slideshow isn't working, so is it okay if I just show it this way?
Yes.
Aditya, my slideshow, when I click, nothing's happening. So I'll just go along like this. I've picked up. We've got a lot of replies to all the slides, and I have picked up the top 3 differentials that has been offered by all the people who have responded, and I'll discuss only these 3. So that among the top 3 responses are number 1, epithelioid hemangioendothelioma. Number 2, as you mentioned, composite hemangioendothelioma and retiform hemangioendothelioma, or combination of both. And thirdly, angiosarcoma. All right. So these all 3 are very good differentials. So before we go on to discuss these differentials, let's see what happened to our immunohistochemistry. We did a very limited immunohistochemistry, and we were mostly looking at it from the point of view of trying to convince ourselves that it is an epithelioid hemangioendothelioma. So for obvious reasons, we did a few markers only. CD31 and CD34, both vascular markers, were positive, diffuse. CD34 was not as much as CD31. And to confirm that it is an epithelioid type of vascular lesion, we did a pancytokeratin, which is also diffusely positive, thereby confirming that it is an epithelioid vascular tumor. Vimentin was also positive. Now, at this point of time, we had the choice of doing more markers to actually find out if it is fitting into either angiosarcoma or hemangioendothelioma. So we had the option of going for markers like epithelial membrane antigen, EMA, which is more likely to be positive in angiosarcoma than in hemangioendothelioma, though both can be positive. And EMA, SMA, smooth muscle antigen, which is more likely to be positive in epithelioid hemangioendothelioma. But we drew a line and we thought it may not be very useful, and so we just decided to match these with what we are looking at in the routine morphology. So by going back, so what we have confirmed with IHC is that it's simply a vascular tumor and has epithelioid morphology. So now we need to confirm that this is either epithelioid hemangioendothelioma or epithelioid angiosarcoma. And so we went back to our slides and we looked at all these. What are our findings then? So we are seeing, let me just kind of reiterate what we are seeing. We are seeing a lesion which is, encapsulated and probably arising from a vessel. Now, both angiosarcomas and hemangioendothelioma can have this kind of picture, but it's more likely to be in hemangioendothelioma, that it's arising from a vessel and it's circumscribed without an infiltrative growth pattern. Okay, so the absence of an invasive infiltrative growth pattern, and I felt there was no coagulative necrosis within the tumor areas. So both these factors again go against angiosarcoma in this particular case. Nuclear atypia or mitotic activity, I don't think were contributory to differentiating these two entities. But finally, the amount of the components, the vasoformative component and the solid sheets, the amount of the proportion of these made us think that it is more likely to be hemangioendothelioma than an angiosarcoma. Because in the books, the angiosarcoma, epithelioid angiosarcomas are described as having a predominant solid pattern and a smaller component of vasoactive, vasoformative moiety. But in our case, the solid area was very focal and limited, whereas the vasoformative areas, luminal RBCs lined by the atypical endothelial cells, these were the predominant components. So we went in favor of epithelioid hemangioendothelioma. So that was our final diagnosis. And as far as your diagnosis is concerned, so we did this differentiation from angiosarcoma. But coming to your differential diagnosis of retiform or composite hemangioendothelioma, as you rightly pointed out, you should have more than one component of hemangioendothelioma. But you must also have a benign component, very well-defined benign component, and an intermediate or a sarcomatous component. but I was not very confident of a benign component in this lesion. Yes, if you can combine hemangioendothelioma and angiosarcoma, you could get two different components. So WHO says that you should have a minimum of two components to call it a composite hemangioendothelioma. But I felt that we could not really apply the term retiform to this entity. So there, I didn't feel that there was an area which looked like, why does it called retiform, by the way?
Because of as it resembles retitestis.
Yes, exactly. So the vascular channels kind of ramify and interconnect with each other and mimic the retitestis kind of appearance. So I'm not very convinced of a large area which had that kind of a picture. So I was more in favor of, or we were more in favor of hemangioendothelioma. So all right, so that is about composite hemangioendothelioma. That's okay, but maybe we need to look at a lot more sections to really say whether this is a composite hemangioendothelioma. For a composite hemangioendothelioma arising in a pre-existing lesion, okay, WHO says that you should have two more components, 4 components. So if you're looking at a composite hemangioendothelioma arising from, let's say, pre-existing vascular, lymphangioma or an arteriovenous malformation or something like that, then you must have 4 components. Otherwise, you could do with 2 components. So, all right, a bit of theory, Dr. Now, Nitishri, are we okay with the timing?
Yes, sir. Another 2 minutes you can take up.
Okay. All right, I'll just quickly go through the theory behind epithelioid hemangioendothelioma. This is described as a malignant tumor with epithelioid endothelial cells and a characteristic myxohyline stroma. Did we find this myxohyline stroma? We did not, right? We did not. So how are we calling epithelioid hemangioendothelioma is the question. This can occur in any site, soft tissue, usually solitary, visceral organs where they're generally multifocal. Soft tissue can produce a painful mass, and those which are deep-seated can be larger in size. Now, the classic form has this particular translocation between chromosomes 1 and 3, resulting in this fusion gene, WWTR1 and CAMTA1 fusion. And this CAMTA1 is available as an immunohistochemical marker. So that is a surrogate marker for this fusion. And this can be seen in the classical form, which have as Cod's nests in myxohyline stroma. And these have minimal ATP and inconspicuous nucleoli. Remember, our case had prominent nucleoli. So it doesn't look like this classical form. No myxohyline stroma, no inconspicuous nucleoli. Then there is another variant which has a different fusion molecule, YAP1 TFE3. Again, it has a TFE3 IHC which is available. So both of these IHCs were not available for us, so we didn't go ahead doing this. But this variant or this subtype, nowadays WHO prefers the term subtype to variant, right? The latest 6th editions remove variants and use the word subtype. Okay, this subtype has predominantly solid and vascular spaces, but has cells which have eosinophilic cytoplasm like ours. Then there is a smaller proportion of atypical cells with tumors with atypical features like greater degree of nuclear pleomorphism, areas of necrosis, high mitotic activity, and diffuse pattern in what looks like what otherwise looks like an epithelioid hemangioendothelioma. And IHC, of course, would be helpful. And these top 5 are markers for vascular differentiation: CD34, 31, portoplanin, FLI1, and ERG. Portoplanin, anyone? What does it? What is it a marker for? I think you can put in your answers in the chat box. What is portoplanin a marker of? Shall I open up YouTube? Okay, I'll give you a few minutes and I'll come back to it. And of course, when you have an epithelioid morphology, you can do the epithelial markers. And as we already mentioned, CAMTA1 and TFE3 are the markers to identify epithelioid hemangioendothelioma. As far as the prognosis is concerned, they behave like a malignant tumor. So hemangioendothelioma is a misnomer. And this was earlier put into an intermediate kind of category, but now it's moved to a malignant category in the WHO. So this behaves as a malignant tumor. And mitotic activity more than 3 per 50 hypophils and size more than 3 are associated with a poor prognosis. visceral lesions, those which occur in organs, as compared to the cutaneous lesions, have a poorer prognosis, and those which have TFE3 positivity are also associated with poor prognosis. So if you have put in any answers, Dr. Nitishri, if you can tell me if anyone's given me the answer to my question.
No, sir. In the comment section, YouTube, nobody has answered.
Nobody
yet.
has.
So
Anybody
may I
can...
have a doubt? Is it of mesothelioma?
No, we are looking at, what are we looking? We are looking at a
No,
vascular
no,
panel.
the podoplanin marker.
Exactly. So I said CD34, 31, podoplanin, FLI1 and ERG are all vascular.
Chaitra has written no lymphatic marker.
She has?
Dr. Chaitra K.
Okay,
Lymphatic marker.
Okay, let me see the comments. Yes, I've got Dr. Pramila also saying lymphatic origin. So congrats, Dr. Pramila and Dr. Chaitra. Chaitra has said vaso. And Dr. Parvati has said endothelial marker. So yes, it is a marker. Podoplanin is a marker for lymphatic origin. So Dr. Pramila has got it right. So good presentation, Dr. Priyanka. Well done. So if you have any doubts, you can clarify now, or we'll move on to the next slide. And before that, here's something coming up as a...
No, sir, I'm clear.
Yeah, Dr. Priyanka, any queries on this?
No, sir, it's clear. Thank you.
Yeah. Anyone else with any queries, please put your questions in the chat box on the KCIAPMSoMe live sharing platform at YouTube. Meanwhile, can you see my screen now?
Yes, sir.
Yeah, what is this? A quick quiz before we go on to the next slide. This is for everyone, not only for you, Priyanka. I'm not seeing any answers in YouTube. Dr. Chatura has commented vasorum in wall and thrombus. Ma'am, I guess you're referring to the previous case. Thrombus formation within the vessel. Yes, yeah, I think that is what we are seeing in that case. Okay, anybody with this slide? I'll move to a high power. All right, then I'll pick it up later. I'll pick up this thread later when we come to the next slide. And we'll move on to the next slide. Meanwhile, I'll keep myself occupied by looking at the YouTube channel to see what all the results are.
There are few answers coming up, sir.
Yeah, I will stop sharing. I will stop sharing now.
Okay, shall we take up with 7th case or?
Yeah, we can take up 7th case, and meanwhile, I'll be looking at all the answers.
Yeah. Okay, now the next case will be case 7. Dr. Shanti Swarupa will be presenting it. Dr. Shanti Swarupa, please introduce yourself and share your screen.
Dr. Nitya, I think I have overshot my time. It's 3:20. I will have to rush up the next 2 cases.
It's visible, ma'am?
Share your screen. Yeah.
Good afternoon all. I'm Dr. Shanti Swarupa, 3rd year postgraduate in Department of Pathology from Radharajeshwari Medical College and Hospital. And today I'm presenting slide number 7. History is 59-year-old female, minor salivary gland tumor for the second opinion. In general, approach to slide is by histomorphological pattern, cellular morphology, and then differential diagnosis. With the help of IHC and molecular genetics, we can conclude the final diagnosis. Coming to the patterns, here there are numerous tumor cells arranged in a microcystic pattern. Image C shows tumor cells arranged in a papillary pattern. Here again, image D shows papillary pattern. Here, tumor cells are arranged in a solid architecture consisting of tumor cells in a nest pattern with intervening fibrous stroma. Image F shows the tumor cells arranged in a glandular pattern. This image shows papillary pattern and also the solid pattern. Coming to the cellular architecture, individual tumor cells shows abundant eosinophilic cytoplasm with the round to oval nuclei and vesicular nuclei. Here, another focus also shows eosinophilic, abundant eosinophilic cytoplasm, and the nuclei is oval to round and vesicular nuclei. Here, tumor cells shows distinct nucleoli, and my differential diagnosis are mammary analog secretory carcinoma, actinic cell carcinoma, low-grade salivary duct carcinoma, and mucoepidermoid carcinoma. With the help of IHCs, that is mammoglobin and S100 protein. If it is positive, then mammary analog secretory carcinoma will be my diagnosis. And also with the molecular genetics, that is ETV6 NTRK3 should be positive. Actinic cell carcinoma usually can present with the basophilic cytoplasm, and cytoplasm will have the granules. But if it is a zymosin poor actinic cell carcinoma, again I have to go with the IHCs, that is S100 and mammoglobin, which will be negative in actinic cell carcinoma. And low-grade salivary duct carcinoma, the nuclear features will be more of mammary analog secretory carcinoma. And also S100 and mammoglobin will be positive for low-grade salivary duct carcinoma. But it is precisely, it is a major salivary gland tumor. And coming to the mucoepidermoid carcinoma, we can see these three types of cells, that is intermediate cells, squamoid cells, and the clear cell type. But if it is a cystic low-grade mucoepidermoid carcinoma, again I go with the IHCs. That is S100 will be negative, and also I'll go with the CTRC1 MAML2 fusion to get the final diagnosis. Thank you.
Thank you, Dr. Shanti. Nice presentation, and you started off with the general approach and then went to the specific approach to this lesion. So that is a nice way of looking at it. A couple of points that I want to ask you is, why have you made these differentials when you're seeing so much of a varied kind of morphology? You got 4 more differentials, right? Couldn't you have lowered it down to a few? Because you've gone from mammary analog secretory type of carcinoma down to mucoepidermoid low grade. But when you're seeing this, I agree that when you see a lot of morphological patterns, you could think of secretory carcinoma. But why did you think of this many, different differentials?
Because of the cytological morphology, sir.
Okay.
Because of abundant cytoplasm, the eosinophilic cytoplasm.
Okay. So you gave a little more importance to cytomorphology than the architectural morphology, right? So that is why you had a wider range of differentials. That is what I feel. Can you, how would you describe the secretory material? You say you're going in terms of your primary diagnosis is mammary analog or a secretory carcinoma, right? Can you just tell me can you just describe how the secretory material in this is looking in this particular case?
In few
Go
areas,
back to your slide and you can just show me the secretory material. Yeah.
in this slide, so we can see the abundant cytoplasm with the monomorphic vesicular nuclei, and also here we can see in
your
this
slide is not visible actually.
Oh, okay. One.
what is the color of the mucin or secretory material that you're seeing?
Eosinophilic, sir. And some places I'm seeing both eosinophilic with basophilic.
Okay. I feel most of it is kind of basophilic. Maybe, as you said, some of them have amphophilic tinctorial properties, but I feel most of it is basophilic. Do you think so? Just go back and look at it. And that is why I'm not very keen on accepting your diagnosis of secretory carcinoma, where the secretory material is more of eosinophilic nature. And I feel that the amount of secretions at the cellular level is also not much. Yes, there are some secretions within the luminae that you see, but overall, if you look at the entire tumor,
Varied patterns.
Yes, varied patterns, and the secretory amount is not that much, even at the intracellular level. All right.
Yes.
Okay, then shall I start sharing my screen now? Okay, I've got, before I go to this, I've got a lot of answers, and everyone has put in Giardia. So great, everyone's got Giardia. Giardiasis, Giardia, Giardia intestinalis. Lots of people have got Giardia, right? So wonderful. So it is Giardia. They look kind of like, some debris in the surface. But if you look carefully, you can make out the pear-shaped structure, which is a giveaway for diagnosis. And they're always found on the surface, and they don't kind of invade into the wall. And especially those which are, adherent to the brush border, they are very difficult to appreciate. So if you find them lying free, and if you notice one of them having this kind of a pear-shaped appearance, then it's easy to diagnose as Giardia lamblia. All right, let's move on to our case. Okay, this was a second opinion which we received. We received about 10 slides, including some lymph nodes. And this was a lesion from the palate. And it was reported by the previous pathologist as a low-grade minor salivary gland tumor with a differential diagnosis offered as a follicular variant of papillary thyroid carcinoma. As you mentioned, Dr. Shanti, there were some areas with kind of vesicular nuclei, right? So that probably prompted the other pathologists to give this diagnosis. And probably that prompted the surgeon to seek a second opinion from us. A differential of a primary salivary gland tumor versus metastatic or a papillary thyroid carcinoma deposit. Okay, so with that, we just move on to the slide. Yeah, this is the slide. Is it visible? Yeah. Okay, we'll start from the surface. The surface looks very circumscribed like, and there is a kind of, what do you think here? This kind of morphology, how would you think of this in terms of gross appearance? So I would think of a lobulated tumor. You can see a kind of depression here and then again a protrusion. So this probably is a lobulated tumor on gross. We don't have the gross findings. Let's move in to a higher magnification. I don't want to see this area because it's a little thick. It appears a little thick. So let's move here. Kind of very cellular tumor, right? At this magnification, some fibrous septae I can make out here, but quite cellular. And as Dr. Shanti, as you rightly pointed out in all your descriptive terms, it has got a mixture or a heterogeneous kind of appearance. You can see these small lobular structures. You can see some nests. You can see nice glandular structures. You can see some solid areas. Okay. You can see some papillary protrusion. This must be a papilla which is protruding and is cut in cross section. So all kinds of structures, a large solid area. And let me go to some other areas. Hemorrhage, no necrosis anywhere, right? You agree with me? No necrosis anywhere.
Necrosis.
No necrosis. Hemorrhage is there.
Just
And yeah, and you can see some cystic spaces here. And what has happened to the cystic spaces? You can see these papillary structures protruding into these cystic spaces, right? So these broad and variably sized papillary into these cystic spaces. So how do you call these? Papillary cystic. All right. Okay, then let's move back to the glandular structures and let's see the content. So here you have some secretory material. I feel they're more of a bluish tinge than a pinkish tinge. Okay, there is some degree of some secretions are present. Let's zoom in onto the cellular level. And this is where I feel there is not much intracytoplasmic secretory material. And all these secretions are like bluish tinged. And at this magnification, one can appreciate the cells. They have a mild variation in nuclear morphology, and not much of a nuclear atypia. And if you see some of the glands, glandular structures have a kind of columnar kind of appearance. See, kind of columnar, making you wonder whether there is a intestinal type of glandular differentiation. And some areas a little more cytoplasm, like a squamous morule. Would you agree? No, you see squamoid morules, like. So are we looking at something with a slight bit of squamoid differentiation?
Sorry to interrupt, sir.
Yeah. Please.
Time limits. It's already been 15 minutes for this case. We have also another case.
Okay. Then I'll wind up quickly. It's 3:30, right? So, okay, what I'm seeing is a variety of patterns with basically not much of nuclear atypia. And let's go back to the PPT so that I can finish quickly. Yeah, this is where I pointed out earlier these columnar cells with slightly vesicular nuclei, which Dr. Shanti also pointed out. Okay, so we are seeing a variety of solid sheets, nests, irregular glandular structures, maybe a vague hint at cribriform pattern, and definitely papillary cystic appearance, round to oval kind of uniform nuclei, focal hemorrhage, and no necrosis. So our primary differential were polymorphous adenocarcinoma, and if things don't fit in, we thought of an adenocarcinoma not otherwise specified. With this working diagnosis of polymorphous adenocarcinoma, we asked for IHC. Before going to IHC, these are your diagnoses. Again, I picked up the top three. The top three diagnoses include, from the responses include mucoepidermoid carcinoma, including all forms, low grade, high grade, and intermediate grade, polymorphous adenocarcinoma, and mammary analog tumor. Okay, we did an IHC, and these are our IHC findings. We did again a limited set of markers to confirm what we are looking at. And on the right-hand panel, if you see, you have these markers which are available for the different salivary gland tumors. And why I put this up is for you to see that there is a large panel of markers which are positive for each of these tumors in the salivary gland, and there is overlap between all these. So there is no unique marker which is present for each of these. So you need to do a set of markers and try to figure out which of these markers which have come positive fit into your morphological diagnosis. So what do we have? We have CK7 positive. Now CK7 can be positive in all tumors of the salivary gland origin, which differentiate or which originate from the luminal epithelial cells. Okay. Then those which are arising from the basal layer or the myoepithelial layer, they will show markers for the bioepithelial or basal markers like P63 and P40. So we had P40 being negative, but P63 being patchily positive. And we also did S100 staining, which is present in some of the salivary gland tumors, but is more than 95% present in polymorphous adenocarcinoma. So with this panel of CK7 positive, P63 patchily positive, P40 negative, and S100 positive, we concluded that this is a polymorphous adenocarcinoma. TTF one was also done just because there was a previous report of a suspected follicular origin, which was negative. So our final diagnosis was polymorphous adenocarcinoma. So we went in favor of this because of our IHC findings. Let us go back to your responses, and this would have been this is my last slide, Dr. Nitya, before we go on to the next one. Yeah. So for mucoepidermoid and secretory carcinoma, both of which do not show the myoepithelial markers or the basal markers, they only show the luminal markers. So that helps you differentiate it from polymorphous adenocarcinoma. And polymorphous adenocarcinoma, I'll skip the theory part. I'll just go back. I'll skip all this theory part. And this is the typical findings in polymorphous adenocarcinoma. CK7 100%, S100 97%, variable other markers like CEA, EMA, galactin-3, BCL2 and KIT. But WHO mentions this pattern of basal markers where P40 may be negative and P63 being positive as of help to diagnose. So we found P40 being negative and P63 being focal positive, which helped us in our diagnosis. So that is about this third case, and a little bit about future aspects on this one. Polymorphous adenocarcinoma. There is a recent discovery, 2019, that there are two forms of polymorphous adenocarcinoma: protein kinase D positive, protein kinase D negative. Implications of these two variants are not known. And nowadays, there is another entity called cribriform adenocarcinoma of minor salivary glands, which is considered to be a high-grade form of polymorphous adenocarcinoma. All right, so I wind up my second discussion on this. Any queries, Dr. Shanti or anybody else, please ask me right now while I'm showing this quiz before I start the third one. Any queries? So this is a case which was earlier known as a polymorphous low-grade adenocarcinoma. Now the term low-grade is no more used because it is known to have a high-grade component also. So it's simply called polymorphous adenocarcinoma. It's been elevated from a purely low-grade to something which can be low-grade or high-grade. So just like the previous case, this also has moved up one step in its prognostic implications. So because it can produce metastatic deposits, and in fact, our case did show metastatic deposits to lymph node also. So any queries on this case?
We
Or
have got, sir,
we'll see.
for the spotter, I think Dr. CK has said it as cryptosporidium part 1.
Yes, that is Chatra madam. So great, madam. Congrats on that. Cryptosporidium it is. And this is going to be very difficult to detect unless you look at it very carefully. And you don't generally get this nowadays. And this was a case from an immunosuppressed patient on following a kidney transplant. And you have to look very carefully at the surface where you see these small dot-like structures which are found on the, studding the surface epithelium of the intestinal wall. So this is, as rightly pointed out, cryptosporidium. So shall we move on to the next case? I'll stop sharing my screen now.
Yes, sir. Next case is case number 8. Dr. Chaitra will be presenting. Chaitra, please introduce yourself and share your screen.
Yes, ma'am. Good afternoon, everyone. Is it my screen visible?
Yeah, yes.
Good afternoon, everyone. Myself, Dr. Chaitra K, third year postgraduate, Department of Pathology from Hassan Institute of Medical Sciences. Case number 8 is allotted to our institution. History is for 51-year-old male with right partial nephrectomy. This is the whole mount slide showing areas of adipose tissue, areas of renal parenchyma, and large areas of fibrous tissue. And here we are seeing multiple varying sized cysts, and these are separated by a fibrous stroma, and also fibrous stroma shows areas of dystrophic calcification, areas of hemorrhage, and a focal area of osteoid metaplasia, and also seen thick-walled vessels and a part of renal parenchyma. And here multiple varying sized cysts which are lined by single cuboidal epithelium, and pericystic area shows few atrophied tubules with thyroidization. And these tubules are seen entrapped in the fibrous stroma. And this is the cyst wall lining with the cuboidal epithelium, and the luminal space shows secretion, that eosinophilic secretion and hemosiderin macrophages. And the septal wall also shows presence of lymphocytic infiltration and hemosiderin macrophages. And an area showing cuboidal epithelium with multi-layering, and these cells having abundant clear cytoplasm with a distinct cell border with small nuclei and without nucleoli. And areas of tubular atrophy with thyroidization is seen, and few smooth muscle cells which are seen arising from the blood vessel in a radiating pattern, and also areas showing thick-walled blood vessels, and areas of dystrophic calcification, hemorrhage, and focal area ossification, and renal parenchyma showing a periglomerular thickening, sclerosing capillaries, tubular atrophy with thyroidization, and interstitial chronic inflammation. Based on these findings, my first differential diagnosis, cysts lining with a single layer of tumor cell with abundant clear cytoplasm and small nuclei without nucleoli with multi-layering, and large areas of fibrous tissue with areas of calcification, ossification. My first differential diagnosis is multilocular cystic renal neoplasm of low malignant potential with foci showing chronic pyelonephritis. For IHC marker for this is PAX8, PAX2, and EMA, and carbonic anhydrase 9. And history of cystic degeneration, extravasated red blood cells, calcification, ossification, hemosiderin-laden macrophages. My second differential diagnosis is regressing clear cell renal cell carcinoma. IHC marker for this are PAX8, carbonic anhydrase 9, and CD10. And based on adipose tissue areas and fibrous tissue areas with thick-walled blood vessels and smooth muscle cells which are seen in radiating pattern, and also varying sized cyst lined by a cuboidal epithelial cells. My third differential diagnosis is angiomyolipoma with epithelial cysts. And IHC marker for this are the melanocytic markers, which are HMB45, melan A, and smooth muscle markers, that is muscle specific actin, calponin, and S100. And a few lines about cyst. It can be a congenital or acquired, and it can present as solitary or multiple, and it is seen anywhere in the renal parenchyma, that is cortex, medulla, and papilla, and it can arise from tubules or glomeruli, and it can be associated with chronic progressive nephropathy or chemical administration. Thank you, sir. Thank you.
Thank you, Dr. Chaitra. Very well presented with all the findings you picked up, including all the description on the inflammatory aspect also. A couple of questions before I start. How would you grade the nuclei if you're thinking it is a RCC, renal cell carcinoma?
Sir, based on the round uniform nuclei, like pleomorphism and
now, what would you,
vesicular.
ISUP grading, nuclear grading, what would you attribute to this lesion?
Grade 1, sir.
Okay, grade 1, good. Okay, fine. The other question I would like to ask you is, your second differential was renal cell carcinoma with cystic degeneration, right? So would you like to do anything to conclude that, apart from IHC? I mean, you don't have IHC, let's say. What would you like to do on it? On the specimen? That's a... On the specimen, like you want to rule it out.
Like based on the secretions.
I've given you only one slide, right? So you want to differentiate it from that. You have I'll give you the specimen. What would you like to do?
The special stain.
No. I'm just telling you the specimen if I give it to you.
Specimen.
Yeah, what I wanted was that you would take more sections, take more tissues, more sections. Look for evidence of a proper regular RCC, which is expansile, how they describe it, expansile RCC rather than a cystic RCC. All right. Okay, so great, sir. Good presentation. So I'll start sharing mine. You can stop your screen sharing. All right, I'm running out of time. I have massively extended my time, so I will just do a few minutes on this. I'm sorry for that, and I will just quickly run through this. As Dr. Chaitra has already mentioned, renal tissue here, and I just want to point out that this is a cortical tissue, not medullary tissue, because I've got a couple of answers saying medullary cystic disease, so this is all cortex. And then you have these cystic spaces and fibrocollagenous tissue. I'm zooming in quickly, some areas of flattened epithelium. If these were the only areas, then it would be very difficult to make a diagnosis. But as we move towards these areas, you're seeing more amount of cytoplasm in the cystic areas. And as you can see here, large amount of voluminous clear cytoplasm. And as Dr. Chaitra has said, its nuclear grading is very low grade. And then you have some areas where there are, you see, what do you think of this? Do you think this is a nest of such cells within the wall?
Sir, multi-layering.
Here you can see multi-layering. What about this? It could be a nest of cells within the septae, or it could be a tangential cut of the epithelial lining, right?
Okay.
Both of them are possible. And one more area I'll show you. Look at this area. Yeah, here also looks like a nest, could be nest, or it could be a tangentially oriented cyst, right? Both are possible. So because for this lesion, that is a very important finding. Then calcification and sclerosis. So basically, what are we seeing now? Let me go back to my PPT. Yeah. Gross, I will not discuss anything, nothing much there. And okay, a lot of cystic spaces lined by large clear cell, abundant stroma and calcification, no significant nuclear ATP at all. So our differentials were multilocular cystic renal neoplasm of low malignant potential, as was yours. Possibility of cystic RCC was considered, but this is a very small lesion, 2 centimeters is what the whole lesion measured, and we have submitted the entire tissue. Nowhere did we see any regular clear cell RCC, which had an expansile growth pattern. So we did not submit additional sections because entirely submitted. So this was a straightforward multilocular cystic renal neoplasm of low malignant potential. And these were your responses. Majority favored the same diagnosis. There were a few which mentioned clear cell or RCC, and some even said microcystic RCC. And a few people missed out the cystic areas completely and only gave the chronic pyelonephritis. I suggest you people please go back and look at the cystic areas once again. So that's final diagnosis was multilocular cystic renal neoplasm of low malignant potential. This is a relatively new entity, but it has a relationship with the classical clear cell renal cell carcinoma in that it has VHL mutations, but it has a very good prognosis. It does not undergo metastatic deposits. Microscopy, when you see, you should not see, what you should not see to call multilocular cystic renal neoplasm is the presence of any sarcomatoid morphology of tumor cells, any evidence of vascular invasion, or presence of areas with necrosis. A very useful pointer to diagnosing this is the presence of nests or single cells within the septa. IHC is of no help because it shows the same kind of features as would any classical renal cell carcinoma. So that closes with my discussion on the 3 cases. For further reading, I would suggest the WHO Blue Books as mentioned here. They are an excellent source for all your material for discussion. And thank you also for your patient listening. And you can always contact me on what I've just shown. And any queries, you can put it up right now or message me or call me up. Thank you very much. And sorry, everybody, for having taken this extra bit of time. And I've encroached on Ravi Kumar sir's time also. I'm sorry, sir. I hope I've tried to cut it down in this last slide. Thank you, everyone.
Thank you, sir.
Yeah.
Thank you so much, sir. Our next case will be case number 4, Dr. Rohit Anurag Jha. Dr. Rohit, please introduce yourself, share your screen and start presenting.
Good afternoon, everyone. I am Dr. Rohit Anurag Jha, third year postgraduate from.
Can't hear you.
I am Dr. Rohit Anurag Jha, from third year postgraduate from the Belgavi Institute of Medical Science.
Yeah. Please go ahead.
We have been allotted case number 4. History goes 74-old.
Not audible.
74-year-old small bowel resection and anastomosis. Here in scanner view, we are seeing the small intestine full thickness section extending from the mucosa to the serosa, and tumor is there extending up to the serosa. In higher view, the mucosal ulceration is there with underlying tumors. The cells of the tumor are arranged in organoid pattern and seeds and the ribbons pattern, and some are forming the glands. These cells are large, oval, with pleomorphic, hyperchromatic to the vesicular nuclei, and places a prominent nucleoli is there. Cytoplasm is eosinophilic, and some cells shows intracytoplasmic vacuolation. Also seen are the bizarre cells, atypical mitosis, and mitotic figures with emboli. A key feature of the slides, focal ulceration of the small intestinal mucosa with a tumor infiltrating up to serosa with large area of tumor necrosis. Tumor is arranged in organoid pattern, diffuse seeds, and at places trying to attempt gland formation. Tumor cells shows the high nuclear cytoplasmic ratio, hyperchromatic to the vesicular pleomorphic nuclei, moderate eosinophilic cytoplasm with few cells showing the cytoplasmic vacuolation. Also seen are bizarre cells, atypical mitotic figure, and few giant cells. On the basis of the tumor architecture and arrangement, tumor morphology, the glandular pattern is less than 30%. We made diagnosis of neuroendocrine carcinoma, large cell type. Other differential diagnoses are the mixed neuroendocrine, non-neuroendocrine neoplasm, and amelanotic melanoma and undifferentiated carcinoma. For further workup, we will go for the IHC study, Ki67, to know the proliferation index, or for the grading that used for the grading of the tumor. For the neuroendocrine differentiation, we will use chromogranin A and streptofycin. CK7, CDX2, MUC5AC, and MUC2, we will go for the adenocarcinoma. Thank you. Hello.
Can you see this? Hello?
Yes, sir.
No.
Can
No,
you
no,
see my slide?
no, not yet, sir.
Now?
No. Click on share button, sir. Click on share button.
Wait.
Now it's visible, sir.
Got it? Yes?
Please go
Did you
ahead.
get this?
Go ahead, sir, please.
Yeah, thank you. So thank you, Dr. Rohit. I think you made a good presentation, and of all the differential diagnosis also you described. Let us go to the one, quiz. Can you just look at this particular picture? It's a gross finding, of a patient. Can you give me what is the diagnosis? A quick diagnosis. You have just 30 seconds to go, or maybe less. This is a lesion in the penis. Okay. Please send those the answers on the YouTube. Okay. Now I'll move on to I'll go back now. Yes. Yeah. Now this is place number 4. We have a 74-year-old man admitted to the hospital with a history of, sorry, let me reduce this. Okay. Hospital, the history of pain abdomen since many days and history of loss of appetite, loss of weight since a few months. There's no other relevant history given at the time of, sample submission. Not able to move. Yeah. Now this is a gross specimen of small bowel resection with anastomosis resection anastomosis with momentum and appendix epiploidy sent for HPE. It has 12 centimeter long small intestine received with attached momentum. The cross section shows ulceroproliferative growth. I'll show the picture, which is measuring about 5.5 into 4 into 1.8 centimeter. This is actually the picture. Look at the gross. The appendix epiploidy is normal in this here in the gross in the first picture. In the second picture, you can see the cut section where it is almost circumferential. The entire circumferential of the intestine is involved. almost is a lot of necrotic area, there's a lot of hemorrhagic, there's some kind of hemorrhagic like maybe black pigment, I'm not sure. But there was some gray weight areas also, in this picture. And you can look at the thickening of the entire wall. It is not gone up to the, it has gone up to serosa, but not involved the serosa. That's what I can see in this picture also. So microscopy is already described in detail what are the important point, but I'll just go through that what is important for us today. Yeah, there is some organoid pattern. You can see this absolutely evident here. Also in these slides, I can see the somewhat of a nested pattern. You can see here. This is a thin fibrovascular core. But what are these cells? They look very pink. Most of them are very abundant cytoplasm. They have a very vesicular nucleus. And what is important is a very prominent nucleoli. Sorry. Okay. So look at this prominent nucleoli in some of these cells. Very, very prominent it is. There is some amount of binucleation, 1 or 2 you can see binucleation also. But overall, somewhere it looks like epithelioid to me. So some people are given a explanation like it's an epithelioid lesion. That's good actually. Again, some kind of an organoid pattern here. Yeah, coming to this, there is very atypical mitotic activity. Lot of atypia, lot of mitotic activity you can see. But again, somewhere it looks like a plasmacytoid cells. You look at this plasmacytoid, but again having a very prominent nucleoli. Again, nucleoli looks eosinophilic at places. In fact, most of the places. Again, some areas of organoid pattern. So the area of necrosis here on the left side, both the sides here. And these kinds of bizarre, cells. I mean, Dr. Rohit already described those bizarre cells. So I'm not going into detail about that. Something called a monster cell, where you cannot describe what it is. Look, monsters. So these cells here also in this picture you can see. So basically, what we are looking at a highly, pleomorphic cells, and whether we can call it as an undifferentiated carcinoma with this picture. Or should we, as you said, Rohit, whether you should call it as a neuroendocrine large cell carcinoma, or is it an anaplastic large cell lymphoma? So these were the 3 important differential diagnoses we had. But when you look at here important is to know that we are looking at both things, not only microscopy, we are also looking at the macroscopy, how it is presented. It is a ulceroproliferative circumferential kind of a growth in the small intestine. That is very important to note. So by looking at the growth pattern, most of the differential diagnosis what you people have given can be actually excluded. Let me go through your differential diagnosis. There are a lot of differential diagnosis from the participant labs. We had 12, neuroendocrine tumor. Then we had GIST. GIST was around 14. They just mentioned GIST. They are not mentioned whether it is a malignant GIST. There's only one of malignant GIST. There was somebody said malignant GIST plus epithelioid, variant. Then paraganglioma was 5. Somebody called it as malignant round cell tumor. Some said it's a lymphoma, probably high-grade NHL. Some said the ALCL. Yes, ALCL could be a very good, differential diagnosis. Only one said it's a purely differential adenocarcinoma. And there are few cases, few people have said it could be a medullary carcinoma of the intestine. And as Rohit also said, there could be a amelantic melanoma or alveolar sarcoma. So getting into all this, because the huge number of differential diagnoses, I'll confine to a couple of things to discuss. So one of the things what Rohit also said, whether it is a neuroendocrine carcinoma, yes, it could be a neuroendocrine carcinoma, but a large cell variety. It's not a small cell variety what we see in the lungs. It should be a large cell variety. I agree with him. But what are the points favoring? Yes, nesting of cells, large epithelioid-like cells, absolutely fine. Necrosis, high mitotic activity index, all are fine. But what is not favoring is the gross finding. Usually, most of these, neuroendocrine carcinomas will have a nodular variant. They'll present as a nodule within the, intestine, either in the lumen or in the wall. But some kind it could be ulcerative, because if it goes beyond the region, it could have ulceration, but not the ulceration what we have seen in the primary lesion of the intestine. And we don't see so many bizarre looking giant cells in a neuroendocrine carcinoma. Even if a large cell, it could be pleomorphism. In fact, some of these cells absolutely look like the large cell carcinoma, large cell neuroendocrine carcinoma of the lung. Absolutely. That's a correct, one of the, I would say, a differential diagnosis. I don't say it is correct. So this is how we can, microscopically, we can rule out that. The second one is about the gist. There are so many, what you call the classification of gist, but I would have been happy if people would have called it as, epithelioid gist. But on that to high grade, but nobody has called it. Many people, I said, called it just a gist. But just simply calling gist, it doesn't make any matter. I mean, any diagnosis for us today. Either you should say it's a low grade or it's a high grade gist. Now, what are the points in favor of gist? Rather than points favoring, I would say the points which are not favoring gist, because gist actually happens. The lesion origin of the gist is from the wall of the intestine, but here you can see it is not within the wall. It is involving actually mucosa and then extending from the mucosa. So secondly, it appears as a nodular growth, not as a ulceroproliferative, what we had seen here. And the cytoplasm, what we see in the gist is, if you're looking at the epithelioid kind of cells, they're less, having less cytoplasm, not the abundant cytoplasm, what we are having in this particular field. And usually, if you look at the epithelioid type of gist, we'll see what is called as paranuclear halo, which is a very important feature. In fact, if you can see that, you can say without doing any, humanized chemistry, you can say this is a, epithelioid gist. That is very important. And look at the giant cells. What you see in the gist is, the giant cells are Teuton giant cells, like, or something like osteoclastic type of giant cells. But you don't see these bizarre looking, mass looking, like of giant cells. And stroma, usually they are mixed in nature. So basically, I am not for this, and you don't see any nested pattern also what you can see. So I don't see that could be one of the differential diagnosis, but if it is a highly undifferentiated, probably yes, we can also think about it. The next one is the, the anaplastic large cell lymphoma could be one of the important diagnosis, differential diagnosis, because the cells all look epithelioid. Okay, and even some of the cells in even the giant cells and all that, it could be so bizarre what you can see even in the anaplastic large cell lymphoma. But only again the problem here is the presence gross finding. But with the gross finding, usually again it's a nodular pattern of growth, not ulceroproliferative. And number two, you are looking, the kinds of cells called immunoblastic cells with epithelioid differentiation. That's also absolutely seen in this particular slide. They all look like epithelioid differentiation, but the hallmark cells, which are nothing but the large eccentrically placed, horseshoe-shaped nucleus with eosinophilic perinuclear clearing, is not seen in this particular case. Okay, so that is also, I feel, one of the important differential diagnosis. Again, nesting pattern is not favoring any of the lymphomas. And of course, donut cells and small round cells are not seen, as you would probably see in the anaplastic large cell neoplasm. Of course, the giant cells, mitotic activity, necrosis, all are, possibly favoring lymphoma. Then there are so many other diagnoses which are offered. I would again put it across. One of them is undifferentiated carcinoma, what Dr. Rohit also put it across. Yes, it is possibly looking at this slide, we can also give a differential diagnosis. But again, the problem here is without probably doing a IHC marker, we are not able to make a diagnosis, because all the other component, like it's a very highly cellular epithelial component is there. Epithelioid cells are there. Epithelial component is not observed here. Usually in a undifferentiated carcinoma also you can see some epithelial component which is not seen here. Sometimes you may also look at the spindle cells. I have got some of the pictures for you to show those differential diagnosis. But again, nesting pattern is not favoring again the undifferentiated carcinomas. Otherwise, the primary lesions in the intestine again favors the undifferentiated carcinoma. Now coming to the other thing, somebody said PCOMA. PCOMA SA is one of the very important differential diagnoses. Again, the gross doesn't favor, because usually they form as a nodular formation. But the cells, some of those cells definitely, yes, they resemble the epithelioid type of the PCOMA. So PCOMA has different varieties. So in that again, epithelioid PCOMA is one of the important differential diagnosis. As Dr. Vani said already, it has two components. One is the smooth muscle component. Other one is the spindle and the clear cell differentiation or epithelioid differentiation. So in some of the PCOMAs, in rather many of them, you also see spindle cells as well as the clear cells. And some said mixed and adenocarcinoma versus neuroendocrine. Yes, but again, adenocarcinoma component not seen. Paraganglioma, again, nesting pattern, yes, but we don't have that kind of typical cytoplasmic granules which are present in a typical paraganglioma are not seen. But and also at the same time, we don't see such kind of bizarre looking cells. Medullary carcinoma intestine, again, one of the important differential diagnoses, I agree, but again, the problem is you don't see lymphocytic infiltrate in any of the tumor areas. The malignant melanoma, I'll come to this later on, but I'm very happy at least many of the people have called it as epithelioid variant of some tumor. That is very, very important to understand. Just to show you the picture of anaplastic, how it looks, one of the DD, what you people are talking about. Here you see individual cells, there's some amount, see the individual cells, very large cells, very pink cytoplasm. Again, there's a lot of spindle cells here, bizarre looking cells. Yes, this could be one of the differential diagnoses. But in any of the neuroendocrine carcinoma, always you see nested patterns. Somewhere, even if you have necrosis, high mitotic index, whatever, but some amount of nesting pattern is definitely seen along with this particular tumor, but giant cells are not very common. Of course, ALCL is one of the important differential diagnoses microscopically, but not, as I said, in the looking at the grass specimen. Now, the approach to diagnosis, the approach to diagnosis is whether I'm looking at primary lesion in the intestine, I'm looking at the secondary. One is the grass and microscopy you must look at. If you look at the grass picture, probably I would say it is a primary malignant tumor of the intestine. Of course, we also look at history. In fact, sometimes when you don't know what is to be done, we pick up a phone and call the physician to discuss, at least to get some, information. So we thought before doing the ISC, we thought we'll talk to the patient, also to the doctor and find out what are the radiological and other data available. Then the third question is whether it is an epithelial tumor or a non-epithelial tumor. Again, we have to look at the grass and microscopy. And then what we are trying to do, IHC, what that we must look into. So what are the IHC? Should we do all the IHC panel that we do in an undifferentiated carcinoma, like from, pancreatin to lymphoma to, melanin to, the undifferentiated, neuroendocrine carcinoma? No, I think that is not the way to do today, because if you can ask the surgeon or a person, doctor in charge, what we did in this particular case is we wanted to ask him before putting ISC that, what is the history? The history he gave me, sir, he had a patient had a small lesion, a black lesion in the extremity of the, one of the extremities, and is taking treatment for malignant melanoma since almost 6 months. So this was the history what we got. So after looking at the history, then straight away we went into the primary, ISC markers of the, of the malignant melanoma, that is the melanin A, it is positive diffusely, except in the hemorrhagic area. All the diffuse, everything is positive. Same thing in all the cells, the HMB45 is also positive, little milder form. Then also we did the cytokeratin just to rule out if there is anything epithelial component we are missing out. Then a symptomizing to look at whether you are looking at the neuroendocrine carcinoma. So this is the summary of the findings. There is circumferential growth in the small intestine limited to serosa. IHC positive for 2 primary markers of melanoma, history of primary melanoma on treatment, morphologically resembling undifferentiated malignancy. So we called it as metastatic malignant melanoma, small intestine. Now, if you don't have the history, what you have done? That's another question, isn't it? Yes, if you don't have the history, or if you look at the, the diagnosis, what you people are looking at, I think the same line, one by one, you must look at what are the markers we can put it across and then come to your diagnosis. As I said, metastatic malignant melanoma, again, the other important thing, which again I was looking at is the epithelioid PCOMA is one of the person who has made diagnosis, because even if you do in this particular case, even in a PCOMA, some of the markers, especially the melanocytic markers, will be positive even in a epithelial PCOMA. That's where you make a false diagnosis if you don't have a morphological diagnosis with you. So here I'll go to the discussion part. See, coming to the IHC, yes, in this particular case, we did HMB 45 Milan A, and these are the other IHC that can be used in melanoma, that is tyrosinase, MIFTF, and SOX10 and S100 protein. Few cases may pose challenges like, you have aberrations in the non-melanocytic marker. They lack the expression of commonly used melanocytic markers. Sometimes it takes 3 months to 3 years to disappear. So, example, a patient has a mass in the lesion, in the body, and if you left it as it is, and if you get after some time, there may be changes in the marker. This is the only tumor which will have so many confusions for the pathologist. Sometimes the central portion of the lesions will be different from the peripheral tumor, which may show different markers. So sometimes there will be a complete absence of all the markers and expressions, and we have to depend only on the history and go to the molecular testing if you don't have any diagnosis. Again, there are some issues with desmoplastic melanoma, like you have tyrosinase, HMB45 Milan A, all negative. Ascended protein may be weak or it's focal. NGF, a marker of Schwann differentiation, is positive. SOX10 may be useful in few cases only. So why I'm telling you all this is, malignant melanoma is not an easy diagnosis. There will be so many expressions. See, sometimes you get aberrant expression for pancytokeratin, CMA52, PAX8, aberrant expression to muscle-specific markers, neuroendocrine markers. So how do you make a diagnosis? So even hematopoietic markers like CD4, CD20, GATA3, which is a urothelial marker, CEA, calretinine, PAX8, PAX2. So many markers will be positive in a malignant melanoma. So only thing is, very important is the morphological diagnosis. What I said is the epithelioid looking cells, pink eosinophilic cytoplasm, abundant, and have a very prominent nucleus with a very prominent nucleus, which is eosinophilic, is the histological hallmark of this malignant melanoma. So in conclusion, malignant melanoma showing aberrant expression of immunohistochemical markers may be mistaken for carcinoma, sarcoma, lymphoma, and even neuroendocrine tumors. So, but the majority of the aberrant expressions will stain at least one of the specific markers melanocytes. So in our case, it has given positive for 2 of the markers. No, even in the primary and secondary, there will be some issues. If the primary malignant melanoma shows some markers positive, the secondary will show something different. For example, primary lesion negative for S100 protein, it may be positive in the lymph node, which is showing S100 positive. So these are some of the problems what you face when you're dealing with malignant melanoma. You should be very careful. Take multiple sections. Do more of the immunohistochemistry, that is, if it's available with you, to come to a conclusion. And again, as I said, take the proper biopsies, or rather the bits from the central part of the lesion, peripheral part of the lesion, primary, secondary, and everywhere. Do the same kind of markers to understand what is happening. This is some of the genetic aberrations what you can see in melanoma. Actually, BRAF mutation, KRAS, and etc. etc. You can read it up. This upcoming subject now, and then take home message is malignant melanoma is a mimicker of all tumors, especially in microscopy. Poses problem with the immunohistochemistry as discussed. Please use all the primary markers for both primary and secondary lesions separately and correlate morphologically always. So that is my presentation. If there are any questions, I can take it. Because of time constraint, I'll reduce the differential diagnosis to minimum.
Thank you, sir. I think there is no doubt in any other case. Shall we take up the next case, sir?
Yeah.
Okay. The last case for today is case number 5. That will be presented by Dr. Gauri Priya Rajiv. Dr. Gauri, please introduce yourself, share your screen, and start presenting.
Is it visible, ma'am?
No. You have to share your screen. Open your PPT and then share your screen.
Just tap on share button. Gauri, are you audible there?
Yes, ma'am. Yes, sir.
Okay. Just click on share button. Yes, it's coming up. Make it full screen. Yes. Go ahead.
Good evening, all. I'm Gauri Priya Rajiv, third year pathology PG of Basaveshwara
Be a
Medical
bit
College.
louder, please.
I'm Dr. Gauri, third year postgraduate from Basaveshwara Medical College and Hospital, Chitradurga. My case history was given as a gallbladder of a 43-year-old female. This is the picture showing the low power. Here section study shows 2 bits of gallbladder tissue. Here itself we can make out that there is mucosal thickening along with hyperplasia of the glands, and crowding is also seen. There are few cystically dilated glands. This is a closer view showing the hyperplasia of the gland along with crowding. This is another picture showing the mucosal folds with hyperplasia. Here we can see that there are glands infiltrating into the muscular layer. This shows that the glands are infiltrating beyond up to the serosal layer. This is the picture showing the forming macrophages in the mucosa. Here, this is a closer view of one of the cystically dilated glands, and we can see that there is mononuclear cell infiltration around the gland. This is at a higher magnification. We can see that the glands are lined by columnar epithelium with bland appearing nucleus, and some of the glands are showing nuclear stratification. In here, there we can it appears like that there are glands inside the lumen of the vessel, so which we can be doubtful of vascular emboli. Keeping all this in mind, I have 3 differential diagnoses to be mentioned. The first one being chronic cholecystitis with adenomyomatous hyperplasia. Secondly, I would like to consider a deceptively bland appearing, well differentiated adenocarcinoma because of the deep infiltration of the glands into up to the serosa, and also because of the doubtful vascular invasion. And my third DD will be adenomatoid hyperplasia. In adenomatous hyperplasia, we will be seeing cystically dilated benign glands with extensive muscular hypertrophy with minimal stromal changes and no cellular atypia. In adenocarcinoma of the gallbladder, there will be complex architecture of the glands with prominent dilatation of the glands, and glands will be appearing parallel to the mucosal surface. Along with stromal dysplasia, there will be nuclear stratification and nuclear atypia. There will be muscular invasion, and there can be vascular involvement. My third DD, adenomatous hyperplasia, will be having hyperplasia along with no cellular atypia. In adenocarcinoma of gallbladder, some of the immunohistochemical markers will be positive, which include CEA, MUC1, MUC2, P53, and keratin 7. There are some other immunohistochemical markers that can also be turned positive in adenocarcinoma of the gallbladder, which will be CA99, IMP3, MASPIN, S100, HER2, and CDX2. There is no definite IHC panel which can clearly differentiate between neoplastic and non-neoplastic, or to differentiate invasive and non-invasive carcinomas. On a final note, I would like to mention that we have to, morphological features are the gold standard in diagnosing lesions pertaining to the gallbladder. And also, we would like to do a extensive sampling to confirm our diagnosis. Thank you.
Thank you, doctor. Can you see my slide?
Yes, sir.
Thank you so much. Yeah. I think that's a good presentation, Dr. Gaudi. I think, but the differential diagnosis can't be benign versus malignant. Okay, so that's one thing you must always remember. You can't give a diagnosis of lipoma versus liposarcoma. That's going to be a dangerous one. Okay, this is a 48-year-old female visited with the private hospital for the following complaints. Specimen consists of a cut open gallbladder measuring 7 into 3 centimeter. The external surface is congested, cut section of the wall appears thickened. I'll just show you the picture. There was some amount of granular texture actually here. There was no evidence of any. See, look at this. This is a gallbladder which is cut section. Actually, there's some few, yellowish stones we see. This is the glistening, yellowish kind of a glistening white and yellowish, a kind of granular material we saw entire throughout the, gallbladder. So this is what she has already described. This is the, villous type of mucosal hyperplasia with papillary folds, proliferative, bland-looking, densely packed. Dr. Gauri, did you see anything malignant in this? I mean, you said some infiltration and all that. Can you say this is an infiltration because absolutely there is no inflammation around that area? The whole gland was intact. So do you still feel it is a malignant lesion? Just think about it. But just remember that gallbladder doesn't have a submucosa or the musculus mucosa. That is very important. So we have Rockett's sash of sinus is also extended up to the perimuscular connective tissue. That is important. And this is what already he has discussed. But the only thing is what I want to bring it to your notice that there was no evidence of ATPR, dysplasia, or anything in this section studied. Okay. So these are the differential diagnoses we got. Hyperplastic polyp, adenomyomatosis, 15 cases, epithelial hyperplasia, 1, adenocarcinoma, 12, flat lesion, dysplasia, intercystic papillary lesions. Again, without, if the gallbladder is looking normal, if there is no lesions, all these differential diagnoses will not be acceptable. Okay, only what we can expect is a hyperplastic polyp, probably to a certain extent adenomyomatosis, epithelial hyperplasia could be a diagnosis. But for the others, you should have even this spongial hyperplasia. I'm not sure this terminology is not being used now. But the adenocarcinoma, flat dysplasia, intercystic papillary, unless there's a lesion in the gallbladder, this diagnosis cannot be acceptable. Okay, but anyhow, you did not know the gross specimen of this particular lesion. Okay, anyhow, let me come to the per se. So I'll not go into the detail. I just want to see a lot of, RA here, Rockett's of sinuses in all those places. Just this is an epithelial. See, what you see here is, if you look at the gallbladder, it's a single layer of epithelium. There's just small amount of folding. But here see the multi-layering and everything is, if you look at the low power wave itself, we can say this almost is looking very benign, very bland looking. So to make sure that you are looking at RA sinuses, you must always establish the connection between the epithelium at the top and the glandular epithelium below. That's very important. So it's a very clear-cut picture here to say it's a RA sinuses. Yeah, this is the infolding and papillary projects in some places. See, there's a lot of crowding of this nucleus, very bland nucleus. Absolutely, there's nothing, but there is a lot of crowding. If you look at this is almost classical what you see in the epithelium, the top of the gallbladder. They are all eosinophilic and basally placed nucleus. Absolutely, we did not find any pleomorphism or anything to suggest it is malignant. The higher power is still to show very clearly. Look at this, very, very clear. There's some secretory snouts here, but otherwise, apart from the crowding of the nuclei, there's nothing else to suggest that it's it has anything to do with malignancy at all. Same picture just to show more of this kind of what Dr. Gauri said, infiltrating nature. Even if you see at the bottom here also, look at this picture here. So at the even at the lower level of the sections also we could able to see bland looking looking cells. This is just to show you, this is the ink marking what we have done. This is the cut section. Probably if you cut occurs again and again, probably you see that it is only within the part of that particular lesion. So here we are looking at an epithelial, grossly there's no lesion. Let us come to this summary. There is absolutely no lesion in the lumen. Grossly there is no lesion. There is a diffuse proliferation of the glands. Is it hyperplasia or is it well differentiated adenocarcinoma is the only thing that we need to look at. Whether what we are talking, Rockett's here, ash of sinuses is really an infiltration or it is just hyperplasia which has gone into the subepithelial tissue. So points not favoring of malignancy is no atypia, no nuclear enlargement, NC ratio being normal, there is no macronuclear, etc. But if it is hyperplasia, okay, what we should look for? So I am ruling out the adenocarcinoma, which many people have said, because absolutely it's very bland. Even the cells which are there at the bottom of the lesion, they are also looking very, very, bland. So only thing you must remember is, in the gallbladder, there are two things you must remember. It has a serosal layer. The anterior and the lateral part, the anterior lateral, what we call it as, it has a serosal, a layer. The posterior and the lateral, it doesn't have any, layer at all, because it is attached to the liver. You must see probably some liver tissue in those places. So there it looks as if it is infiltrating. Because there is no serosa, you're not able to make out. But if you take multiple sections, you must see multiple sections to ensure that it is within the glandular, within the muscular coat of the, the serosal coat of the gallbladder. So this is very, very important to ensure that you take multiple sections to ensure that there is no pilferage of these cells beyond the serosa, beyond the muscular tissue of the gallbladder. That is very, very important when you're talking about the posterior aspect of the gallbladder. I hope you understand what I'm talking about. But what is that we are supposed to see is that you must look at the metaplastic changes in these epithelial hyperplasia. Did you say any, Dr. Gauri, did you say any metaplastic changes? Did you mention anything about metaplasia? No?
No, sir.
It's fine. So why metaplastic is important? Because it is one, some of the metaplastic lesions are very, very important. I'll just go through just for sake of a discussion, especially for PGs. We can have pyloric metaplasia, we can have intestinal metaplasia, we can have neuroendocrine squamous, or sometimes pancreatic acinar cell metaplasia also. But most commonly what we see is the pyloric. This resembles mycorrhizal glands of the pylorus. Any lesions which is less than 1 centimeter should not be called as neoplastic. This is the dictum even in the radiology also. Anything above 1 centimeter should be called as neoplasm. So if you do a very careful watch in the gallbladder blood neck region, you may see some of these cells which resemble the metaplastic, especially the subepithelial mucosal glands what we see in the neck region. So you have to be very careful when you're looking at these cells and don't call them as metaplastic cells. So these are seen around 8 to 12% of cholecystectomy specimen, not a pre-malignant per se, but in presence of stones or porcelain like gallbladder or in the advanced age, they can become malignant. So this is I have taken from the textbook. This is a very nice picture. What you can see is the metaplasia. This is the pyloric metaplasia here. You can see this is the top layer of the gallbladder, pink eosinophilic cytoplasm. They have basally based nucleus, and below you can see the difference. Totally, there are very clear cells mucosecreting, and you can see the basally flat lining epithelium. So this is a pyloric gland metaplasia. Now coming to the intestinal metaplasia, we have 15% of cases. The goblet cells are seen commonly. Rarely you see Paneth cells. This metaplasia has some correlation with gallbladder cancer, as incidence of this is very high, especially the dysplasia and carcinomas. So especially when the patients are coming from the high risk regions. You can see people who are coming from Delhi and other places. There's some cancer. I'm also part of the cancer board meeting, which we are also looking at how to diagnose the early cancer diagnosis by ICMR. This project is going on. Why this is important is because there is a very high risk in the northern India, especially in the Ganges area. So people who are living in the Ganges basin, you must have a proper analogy and look into what is that we are looking at. Even if you find a small lesion in the radiologically, you must be able to take it out in these risk regions. So in our country, the northern India and the Ganges area is the risk region where we will get a lot of cases compared to the Bangalore population or any other populations. So that's why the intestinal metaplasia is very important. Neuroendocrine carcinoma metaplasia is very uncommon, can be demonstrated by immunohistochemical stains. Squamous cell metaplasia can be only seen in porcelain gallbladder where it has become very thick like porcelain. And the pancreatic cell metaplasia, it's very, very rare. But again, you must know all these metaplasia because unnecessarily sometimes we make it a diagnosis of carcinoma if we don't have proper knowledge about the metaplasia. This is just to show the intestinal metaplasia of the gallbladder. Look at this. These are the goblet cells. So these are the metaplastic cells. And this has got a high risk of getting into malignancy. So whenever we say chronic cholecystitis, when there's some amount of hyperplasia, please take some more sections, take deeper sections to look for any kind of metaplasia, especially in cases of chronic infection, especially people having multiple stones. They are the ones who get a lot of metaplastic changes as well as dysplasia. Another important thing we must look in the gallbladder epithelium when we see hyperplasia is also the dysplasia. So we also have low-grade dysplasia and high-grade dysplasia, like what we have in GI tract. We don't call them as carcinoma in situ today. So what is the thing that we need to recognize is the necromegaly, hyperchromasia, increased sensitization, like what you see in other places also, like in cervical carcinoma. Same thing is also to be seen here as well. Okay, and low power itself is sufficient to make a diagnosis. So if you put under the scanner also, you can make out that little bit of hyperchromasia. There will be some changes in the coloration of the cells, which you can glands rather, and you can look into that microscopically, looking in the higher power view to make a diagnosis. So just to show between the difference between the low power as well, low grade dysplasia versus the high grade dysplasia. This is the low grade dysplasia. See, some of the epithelium is almost normal here. There's some amount of hyperchromasia. That is, the polarity of the nucleus is slightly, it is moved away from the normalcy. But whereas in the high grade dysplasia, look at the polarity. The polarity is almost lot. You can see, look at these cells, nucleus almost coming to the surface, epithelium. The surface of this individual cells, you can see them. See here. So this is one important area of concern when you look at whether to call it as a low-grade dysplasia or the high-grade dysplasia. You can actually, Dr. Santosh, told me this particular point, which is very, very important. Look at the nuclear morphology. Look at the nuclear, presence, whether it is almost occupying the entire length of the epithelium up to the surface. Then you can call it whether it is a high-grade dysplasia or a low-grade dysplasia. Because other things are very, very subjective, it's variable. So you may get into confused. Even in the intestinal, dysplasia also, you must have the same point, which I thought is very, very important to understand. Otherwise, another important point is the stratification. You can see some amount of stratification in the high grade dysplasia compared to not so much of stratification what we see in the low grade dysplasia. So importance is to know not only metaplasia, which type of metaplasia, whether we are dealing with dysplasia or not dysplasia. If it is dysplasia, whether it's high grade dysplasia, it's low grade dysplasia. Now, how to differentiate from the well-defined adenocarcinoma? As I said, important thing is the size. Size is very important. If it is more than 1 centimeter in your in ultrasound examination or in MRI or CT scan, you have to think of possible malignancy in this particular lesion. Any polyp more than 1 centimeter has to be operated. There is no other thinking about it at all, not leaving as it is. It has to be removed, and most of them, 95% of them will not be malignant. But by and large, which as per the the definition, if any polyp or any lesions which is more than 1 centimeter, any thickening of the wall also in the gallbladder more than 1 centimeter, you have to remove and rule out malignancy, because 5 to 10% malignancy is common in these lesions which are more than 1 centimeter. If it is less than 1 centimeter, you can do a follow-up. You can do scanning and see whether it is really growing or not growing. It's up to the clinician to take a call. So in our microscopically, there is no evidence of high-grade dysplasia, no pleomorphic cells. Okay, so we just thought we'll do an immunohistochemistry just to make sure whether we are looking missing or rather malignancy. So actually, Dr. Gauri said it is not very important, but CA is one of the important marker. I'll tell you why. S100 protein also is being used in some of the earlier days, and then CK19, CK7 are positive because there are epithelial cells, and P53 are positive, they are only weak and diffuse, and Ki67 is moderate to high, proliferating in high proliferating areas we have found. But let me have just a look at this. This is CK19 positive diffuse, CK7, it is positive throughout. You can see everywhere, all the glands, wherever it is there, it is positive. And CA is negative. That is, yes. CA, I'll tell you 1 minute what is the importance of CA. Then PA68 is focally and weak positive. Probably there is some amount of generative process happening. That's why this P60 has taken positivity. Now, in our case, there was absence of CE expression, gallbladder mucosa as well as in the RA sinuses. P53 weak focal positive, I said, because of regenerative process. So there are a lot of studies on expression of CEA in gallbladder epithelium have concluded that from cases of dysplasia to invasive carcinoma, the amount of immunoreactivity, that is important. CEA progressively increases and shows a change in distribution. This is very important. That's why the CEA is also still, if you have a doubt, as you said, benign versus malignant, Dr. Gaudi, you should again do in such cases a CEA and find out whether these kind of changes seen in the distribution of the glands and the cells. In malignant tumors, in addition to a stronger staining reaction, CA could also be seen within the cytoplasm and even in the gland secretions. That is important. So the microscopic findings of the absence of atypia or dysplasia and also negative CEA on IHC helped us in confirming our diagnosis. Hence, we diagnosed it as florid hyperplasia with deep-seated RA sinuses and cholelithiasis was offered. And one small last slide, I think this is to differentiate between hyperplasia, which is primary and secondary. The primary hyperplasia, do you know it can occur in the gallbladder, but it's very rare. But the secondary hyperplasia, when you see like in a chronic cholecystitis or stones or in injuries and all the other area, I mean other lesions, it is very, very important to differentiate to find out whether they have, as I said, any of the metaplastic changes, or if they have some dysplasia, you must take multiple sections and rule out whether they have these kinds of lesions. Okay. Sometimes, rarely, we can also have diffuse hyperplasia in a polyp-like lesion, but it's very, very rare. These are the references I have taken. I have taken even the textbook reference from Ackermann Surgical Pathology also. Thank you. So that is the end of my presentation. So anybody has any question, they can ask me. At the same time, what happened to my quiz? This thing, Aditya, Nitya, did you get any answer for my quiz?
Yes, sir. Only one person, two people had answered it. Dr. Sudarshan Krishnappa had answered it as Fournier's gangrene, and Dr. Chatura Kasim Setti has answered it as priapism.
I'll give it, this is a COVID era. We're all in COVID. So will they want to make a differential diagnosis? This is a very interesting case we had. It's a mucormycosis of the penis in a non-COVID patient. So, so this is very, very rare presentation I thought of sharing with you all. So if the time comes, we also make a publication of this case. Fournier gangrene is a very correct diagnosis because grossly this is the diagnosis they'll make, by the clinician. But fortunately, we saw this. This is case of mucormycosis. The entire tissue, the entire penis, the 1/4 of the penis had only mucormycosis, nothing else. And after a partial amputation, the patient is now all right. So that's a good diagnosis we had from the doctors. Okay. Thank you so much. And any more questions? Any questions in the other areas from the chat box?
No, sir, no.
Taking too much of time, I think people are probably fed up. They're fatigued.
Sir, okay, now I think that was a really wonderful session at the end of the day with all our residents giving us their enthusiastic presentations, and consultants presenting to us with so much elaborated explanations. I hope all our audience viewers have got many new things to learn and assimilate, and also I think they would incorporate these methods and approaches in their future diagnosis. I also thank all the consultants for their interesting cases and spotters in between. For this session to Dr. Vani ma'am for the closing words.
Yeah, thank you, Nitya. So we have come to the end of the KCIAPM slide seminar. Actually, it's more a big relief for us because we have been preparing for this amidst our busy reporting schedules. And Dr. Ravi also amidst his innumerable number of meetings and other things. So it's a relief for us, probably a relief for you also, because you have been doing a lot of reading and references to make the correct diagnosis. The quality of the presentation by the postgraduates is really very good, and I think you guys are able to approach very nicely. So keep it up, and do attend more such slide seminars, and try to hone your skills even a little more. Okay, you're on the path, but I think a little more honing can be done. So like certain things like where there is no fat at all, we cannot think of any lipomatous tumors like that. We have to fine tune our skills, but otherwise I think overall it went on well. I think it is 4:40 now. 10 minutes we have overshot, and sorry for that from our side. And I look forward to the next year's KCIAPM slide seminar. Already we have started looking for our slides for next year, maybe with more spotters. So see you soon next year. Thank you.
Ravi sir and Santosh sir, closing remarks. And we request Ravi sir, Santosh sir, and Imran to choose the best presenter, case presenter of the evening.
Thank you, Aditya. I think I had an excellent, learning session actually, because I'm so busy nowadays. I don't see slides because I'm into more of admin. But whatever the knowledge and all the other things I have, I think the presentation was excellent, especially from the post-graduation. As Dr. Vani said, the approach has to be perfect. When you have a perfect approach, I don't think you miss any diagnosis. So that is one thing we need to learn. As he said, there are so many online, these kinds of programs going on. You can also look after that by, what is that? We call it, even if we are busy, we can go on, SOTA, what is it called? Something called. So you can go back and also see in your, YouTube channel and learn. So this is a learning process, and I think even I would have been very happy if there's a one-to-one, conversation with the PGs. That's how we enjoyed actually. Basically, I was a teacher, so I enjoyed that, asking questions like Dr. Santosh did, but it took a lot of time. So I had to ask him to, go fast. Sorry, Dr. Santosh, I had to intervene him and say, hey, don't ask, you are going very slow. So thank you so much, and all the best for everybody.
Thank you, sir.
Thank you, Aditya. Thank you, Dr. Nityashri. Thank you to all the participants. It's been a wonderful experience, and it's been a pleasure going through this session. And I hope you've had some, good thoughts to take back with you at the end of this session. Thank you all.
Thank you so much, sir. And now can we have best presenter, ma'am and sir?
That's a tough job. Actually, I hadn't noted it down.
I leave it to Dr. Vani and Dr. Santosh.
If necessary, you may discuss later and share the opinion later also, ma'am.
Okay, that would be appropriate. Yeah, I think so.
Yeah, that's fine, Aditya.
Yeah, we'll do that.
Sorry, I forgot to make a mention about Dr. Aditya and Dr. Nitya. I think Dr. Aditya, please, everybody has to clap. I don't know, you do the clap through this, I don't know how. Clapping, because he's been with us since yesterday, today. He spent a lot of time. I should appreciate him, and my full heartfelt thanks to both of you. Thank you so much.
Thank you so much, sir.
You're welcome, sir. Thank you, sir. With that, I thank all the audience for joining us today, and we shall close the session now. Thanks a lot.
Thank you.
You all to stay back here.